Good afternoon and welcome to the Royal Society of Medicine and our webinar today in collaboration with Lipoedema UK. My name is Julia Manning and I'm the Dean of Education at the Royal Society of Medicine. We're a 220-odd-year-old charity for members, and we deliver healthcare education through webinars such as these, through in-person conferences, workshops, and communities. And we bring together stakeholders and speakers to share learning practices with the aim of improving patient outcomes. And our members also benefit from really superb library and information services. And not only can you have access to online journals and point of care insights, but you also have a great team to help you find the information and research that you're looking for. So today, as I mentioned, we are partnering with Lipoedema UK, and I am absolutely delighted to have with us Cherie Fetzer, who is the chairman of Lipoedema and who has worked really hard together with her colleagues at putting together this afternoon's programme. We've got a superb lineup, and I just want to say a thank you before I hand over to Cherie, to our anonymous donor who has made today possible and made this online education in partnership with public-facing health charities a reality. So thank you so much for joining us. And Cherie, really lovely to have you with us. And I'm going to hand over to you now.
Thank you so much, Julia. We're only 14 years old, so I feel very honored to be partnering with. I was honored to start with, but now I feel it's even more an important step in our evolution as a charity. I'd like to welcome everybody who's joined us today, especially those who joined our 2020 or attended our 2025 RSM webinar. If you were one of the people who missed it, it's still available on the RSM YouTube, and I do recommend it as complimentary to today's programme. Today's event will be recorded or is being recorded, and you'll be informed when it's available, when the recording's available by the RSM. There will also be a 10-minute comfort break in the programme at 5 o'clock. If you have any questions for our panel of speakers, please put them into chat, and the individual chairs will put them forward to our speakers during the panel discussions at the end of each section. What absolutely amazes me is how much has happened since our 2025 RSM webinar. After spending so much time in the shadows, lipedema is now truly in the international spotlight, including following celebrity Doja Cat's late night revelation when she suddenly realized she has lipedema, an article in Time magazine. However, the danger of so much attention is also the proliferation of misinformation. It is vitally important to seek out reliable resources, such as the RSM, the Lipoedema World Alliance Delphi consensus paper we'll be discussing today, our own Lipoedema UK website, and the comprehensive resources available from the Lipoedema Foundation. Diagnosing lipedema still depends on a dedicated and thoughtful clinical diagnosis. As you will hear, there are no tests yet. The LWA Delphi consensus paper is the combined wisdom of many of the world's most experienced clinicians, researchers, and patient organizations. In Germany, the government's funded research project has been so conclusively positive, this is since our last webinar, that they have announced they will be funding surgery for all eligible patients with lipedema. Yet despite these steps forward, individual patients continue to feel isolated, abandoned, and frustrated because almost all of the world's medical institutions continue to totally ignore lipedema. If you are a medical student or in any profession, my hope is that you will become a compassionate ambassador for lipedema in your professional life, taking steps to shine a light towards the latest knowledge and most effective treatments for the patients in your care. If you are a patient or a carer of a patient, it can be a long, lonely journey, but I hope that today's event will empower you to challenge those who, through no fault of their own, are still ignorant of the existence of lipedema and the debilitating impact it has on lives. Finally, thank you to the wonderful team at the Royal Society of Medicine who have helped us create today's event with great professionalism and empathy. And I'd like to thank our whole Lipoedema UK team. We're quite small, but we're out there doing a lot, and especially Mary Warrilow, who's done so much for today's programme. A huge thank you also to all our speakers today. Each one from various parts of the world is a wonderful individual who has looked beyond the status quo of their professional skills with curiosity and compassion to make the world a better place. Thank you everyone for being here with us today. I'd like to start our programme today with Dr. Anne Williams, Nurse Consultant and Research Advisor to Lipoedema UK, who will start off the programme with what is lipedema and the importance of an early diagnosis.
Thank you, Shari, and thank you so much for the opportunity to be here, and welcome to everybody to this online space. I'd like to add my thanks to the Royal Society of Medicine for giving us this opportunity to have this important discussion. So I've been asked to talk for 20 minutes on what is lipedema, the importance of an early diagnosis, and I have no conflicts of interest to disclose. I've also been asked to draw on the Lipoedema World Alliance Delphi consensus position paper that Shari has mentioned. And Dr. Krupa is going to follow me in the next session, so you'll hear a lot more detail on this, but I am going to draw from it in my session. And I would like to say thank you to all the authors and the participants in this Delphi consensus work, because this is really important step towards understanding and teasing out some of the real difficulties that we have in developing evidence to support people who are living with lipedema. So you will hear a lot more from Dr. Krupa, but essentially this Delphi consensus paper, which was published earlier this year, has 59 statements about lipedema within 8 domains, and I'm going to look at 3 of those domains, and I'm going to tell you a little bit about the agreements and the issues that have been raised in the paper. So what I should say, and Dr. Krupa will probably give you more detail here, but I have really shortened, rather than putting the whole statement on each slide, I have shortened these a little bit. You will find all the details on the paper. There's a really well set out table that gives you details of the levels of agreement amongst the experts that took part in the study, which includes researchers, clinicians, and people living with lipedema. So if we look at domain 1 and we look at, these are some of the 11 statements, you'll be able to see immediately there's quite a high level of agreement amongst the people who took part in the consensus of these different aspects of lipedema. And you'll see already many of you are be living with these symptoms every day, or you'll be clinicians that are working with people with lipedema, and you'll see it's a chronic condition, symmetrical bilateral enlargement of adipose tissue in extremities with pain and discomfort. A real feature is a disproportion of extremities compared to the torso, and the involvement of upper extremities in some people, with the hands and feet spared, and the physical sensitivity to pressure and pain. So again, this will be very familiar to many of you, and in this domain, you can see overall a really high level of agreement for each of the statements related to these different symptoms: swelling, heaviness, bruising, the absence of pitting edema, and the negative Kaposi-Stemmer's sign, which again, these last 2 differentiate lipedema from lymphedema. So again, if you're new to this, you'll get a lot more information on these different symptoms and characteristics on the Lipoedema UK website. But again, this paper then begins to give us some of the challenges around this. So whereas there is a high level of agreement across 11 statements in terms of symptoms, you'll see the paper then begins to tell us that, okay, a characteristic lipedema phenotype exists, but actually there are variations in clinical presentation, lack of clarity, asymmetry may occur. So, for example, I see quite a few people who perhaps have had knee or hip problems as a result of the lipedema, and the fat lobes that will change the shape of the leg and make walking difficult, causing problems to the joints. So again, if someone has a knee replacement or some other damage, the secondary acquired lymphoedema may even occur. So asymmetry may develop. So again, other areas of issues to be considered is, are the arms always involved, and what's the etiology for bruising? Has that kind of developed for different reasons? Another really important area that we've got to think about in terms of lipedema is pain. It's not simply adequate to give people strong analgesics without understanding of what is the pain in lipedema. Is it tissue pain? Is it joint pain? Is there something else? So we've got to look very carefully at these areas. So pathophysiology, domain 2. There are 4 statements in domain 2, and your eye will be drawn to probably the high level of agreement that lipedema involves adipose tissue and that hormonal factors contribute, although we're not entirely sure how they influence lipedema, but we know lipedema often develops around puberty or times of hormonal change. But you'll also see there's slightly lower levels of agreement relating to inflammation in lipedema and tissue fluid volume. So I'm going to look at those two just with 2 slides, because these are interesting areas of contention that we do need to understand better. So in the paper, in the Krupa paper, they very usefully say it remains unclear whether tissue inflammation observed in studies is a cause or consequence of lipedema. And you can see nearly 61% of the participants agreed that additional evidence is required. And this is really important because when we look at papers often talk about, oh, lipedema is associated with inflammation, but actually we don't really know how should that be measured, what's the implications of that. And in women, trying to understand that, maybe look at nutritional approaches to reducing inflammation. And again, we don't really have enough evidence around any of that to be really sure what this involves. So the paper's been very useful in raising that. Equally, the consensus paper also reminds us that, okay, there's evidence from various studies that indicates that lipedema may be characterized by accumulation of excess extracellular fluid, and that may be related to impaired blood capillaries or dysfunctional lymphatic vessels. But again, you can see 66% agreeing additional evidence is required. And this is really quite an area of contention as to how much lymphatic insufficiency is some element of lipedema. So again, very useful to see that brought out in the paper. And of course, when you're a clinician looking at making a diagnosis of lipedema, you would want to differentiate very much lipedema and lymphoedema. And of course, in this picture, it's quite clear. You can see the one on the left, and the woman in the left has got lymphoedema. It's unilateral. If you were to put your hands on that, it would probably be warm. It would feel quite firm, quite hard. Whereas on the right, you've got the symmetrical changes of lipedema. However, the difficulty is, of course, that we may, and there is evidence in some women may have a primary lymphoedema problem along with lipedema. So it's not always totally clear cut here. So again, some challenges for us. And additionally, for many women with lipedema, weight gain can be a characteristic of lipedema. We don't entirely understand why additional weight gain happens often with many women. And that problem can then lead to compromised lymphatics and then a potential secondary lymphedema as a coexisting condition. And it's worth noting that the term lipolymphedema, which has been used in the past quite a bit, is not used now. We do tend to look at this as a secondary lymphedema. But what's really important is these women are signposted to the right places for the right help and may require decongestive and compression therapy. And then looking at domain 6, diagnostic approaches, again, you'll see quite high levels of agreement that diagnosis relies on medical history, clinical examination, exclusion of differential diagnoses and no imaging, has already been said, no real tests. And this is a real challenge for us because you'll see, if you're new to this, that how subjective the diagnosis might be. And again, quite confusing, again, that lipedema is sometimes classified into stages, but the consensus document has said, well, a high-level agreement that the stages do not relate to symptom severity and really have limited relevance for disease management. So this raises a lot of questions for us around how we, diagnose and how we understand lipedema. And we've still got a long way to go to that. And just as an example, what you will often see in the literature is an outline of stages and types of lipedema, but there really is a lack of consensus on this. And a lot of it is based on, it's not really based on underlying pathophysiology, it's based on shape and size, and really often used for making decisions about surgery, for example. But again, we've got a long way to go to fully understand really these different types. And I kind of hope that in years to come, a bit like we've had with primary lymphedema, we will have quite a complex algorithm that has drawn on some of the genetic understanding that hopefully will come around lipedema. And of course, women with lipedema are individuals as well. So although you may look at a picture of someone with lipedema and say, well, you see a woman perhaps in the clinic and she doesn't look the same shape. In fact, some women have an ankle overhang and quite a columnar shape below the knees. Others do not have. They may just have the lipedema in the thighs and hips. Likewise, some women may have issues with weight gain that doesn't respond to dieting, and that can be quite difficult to differentiate then the lipedema. So it takes some time to find out from women about their previous experience and body shape. And of course, the real difficulty is that lipedema and obesity often may coexist. And in fact, when you look at definitions of obesity, they talk about impairing health and leading to increased risk of diabetes, heart disease. But in fact, the evidence is beginning to show perhaps that isn't the case in lipedema. Lipedema does not lead to an increased risk potentially of these conditions. And we need more evidence to show us really what is the case in that situation, because too many women with lipedema are being told that they've got weight gain, obesity, and then referred to clinics that don't necessarily understand lipedema. And this is a really important example of why that understanding of lipedema is so important within weight management clinics and within practice. So this is a woman who agreed to share her before and after slides with us at Lipoedema UK. And you can see before the bariatric surgery, you can see the shape, you can see after bariatric surgery. What's really startling is that lipedema shape and leg shape and lower body shape is still there. And that's really difficult for women. That's something that we, that again is a challenge going forward, and we need weight management services to understand and do a full assessment so they can be sure, has somebody got lipedema before they go through different treatments. So important questions remain. We need more evidence to understand progression, stages, different phenotypes and genotypes of lipedema. without a doubt. And I wanted to draw your attention to the UK study of 200 women that was published in 2022. This is really interesting. Took place at St George's and in Derby, 2 specialist centres. And you might be interested to see 71% had tenderness or pain on pressure. So not everybody had pain. And that's a real interesting one when we start thinking around, how do we diagnose lipedema? Is it only related to pain? Again, 27% had some edema, mainly in those over 35. So again, we're showing there, perhaps there's some lymphatic insufficiency. So we need to understand that more. Venous problems, family history in just over half. So you can see there's still a lot of things that we really need to understand. In terms of genetics, there is some other work, and these are just 2 examples. There is some work ongoing, and all the time we're hoping to understand this more. But the Gregoriadis study looked at genotyping on 130 of the 200 women that I showed in the earlier slide. And Morgan's undertaken a study as well. But the message that comes through is there's real genetic heterogeneity here. It's still quite confusing. Lipedema is not caused by a single exomic genetic factor. So we've got some way to go before this becomes a route to diagnosis, but hopefully it will in the future. So if you're a clinician diagnosing lipedema, if you're new to this, the main message to give you today is that history and examination are both important. You will hear the story from the woman. It will often start at puberty or, as I say, times of hormonal change. There may or may not be a family history, but what we need you to do is put your hands on and look and see the changes in body shape, feel the soft floppy tissues that are often painful to touch, and hear the stories of the difficulties with using lifestyle changes, dieting and exercise to manage lipedema, because that's very challenging for people. So, potential importance of an early diagnosis. Well, yes, taking back control and realizing you're not to blame is very, very important. And so could be argued as a real reason for early diagnosis. Might be possible to reduce the burden of living with unexplained symptoms, which many women do for decades. By diagnosing, we allow women to focus their efforts on effective management strategies and perhaps minimize the long-term physical and mental challenges. And these are outlined very clearly by Mary Warrilow in the Lipoedema UK survey, where you'll hear more about this today from some of the other speakers. But what I would say, yes, early diagnosis, but what are the challenges? You've heard there that we've got limited evidence and consensus in relation to some aspects of lipedema, some aspects around diagnosis and treatment. We don't have robust evidence for some of the treatments. And what we now have is really a real lack of infrastructure in the UK for this to happen. And we, Lipoedema UK and beyond, are working really hard to try and address that and look at pathways of care for women, because as with any screening program, you cannot screen people for a condition unless you have something to offer them. So that's our big challenge now. And if not, there's the confusion, concern and fear for women that continues, particularly as they rely very much on social media for information, for self-diagnosis, diagnosing each other. And that's not the right situation that we need in the UK for women with lipedema. Thank you.
Thank you so much, Anne. That was a really fantastic summary, and your years of experience with lipedema patients really shines through. I'd now like to introduce Dr. Philip Krupa. Philip is in Germany. He's a consultant plastic and reconstructive and aesthetic surgeon. He has a fantastic knowledge of lipedema and long experience of surgery on patients. And he's currently at the University Hospital Schleswig-Holstein in Germany. Thank you, Philip, could you please give us the background? And you are, in my eyes, the architect of the whole global consensus. And thank you very much for all the work you've done on it. I know it's endless, endless hours that you've put in.
Thank you, Sherry. Thank you very much for your kind introduction. And the goal of my lecture today is to give you a bit of a context, how this project emerges from the very beginning and what are the technical details in the making. My name is Philipp Krupper. I'm a plastic surgeon in Lübeck, which is in northern Germany, very beautiful area here. And I'm specialized not only in lipedema, but also in lymphoedema surgery. So the clear distinction between lipoedema and lymphedema is something that is a part of my everyday practice. So having a consensus is essential to have a clear understanding what lipedema actually is. And this currently varies in between countries and continents. I have no conflicts of interest. The initiative for this work originated from the Lipoedema World Alliance, a professional and non-profit organization that was founded by 103 professionals from diverse backgrounds, clinical practice and research and patient advocacy. And the main goal of all our members is to bring together this varying perspectives on the disease lipedema. So we want to promote genuine international exchange across multiple levels while still integrating the patient's perspective. One key outcome of our efforts is the association's position paper called Lipoedema World Alliance, Delphi Consensus-Based Position Paper on the Definition and Management of Lipedema. Long title, and I try to summarize the key aspects today. Why do we need a consensus? Because in many ways, the only thing the various national guidelines and the existing consensus publications have in common is it is not normal fat. We identified a number of problems. First, we face inconsistent diagnosis across the different regions, which complicates the global understanding of the condition. Next, we encounter varied treatment plans across different healthcare systems, making it challenging to establish a universally accepted protocol for managing lipedema. And this inconsistency further leads to patient confusion. Having conflicting information about the condition makes it difficult to fully understand and manage their own health effectively. And finally, all these issues pose significant research challenges as well. The difficulty in comparing studies and outcomes across different regions and treatment methods hinders progress in understanding and treating lipedema ultimately. Why did we use the Delphi technique? Because it makes perfect sense for this purpose. Delphi studies are facilitated when complex topics with limited evidence are discussed. These studies are conducted through multiple survey rounds with anonymous feedback, and gradually to converge towards a consensus. The advantage is clear, it's structured, it's transparent, and it minimizes the influence of dominant individuals. It enables the inclusion of interdisciplinary expertise and different perspectives, but still we have the limitation that there's subjectivity involved. We have a bias from the very beginning in our expert selection, for example. And last but not least, this is time and resource intensive because it requires multiple rounds of feedback analysis. In the following slides, I present you the modified Delphi process that we used in this study. In the first step, we selected a project team. We formulated provisional statements and recruited our experts. The expert panel in this case was all of the 103 Lipoedema World Alliance founding members. For the first round that took place in September 2023, currently half of our founding members voted on this provisional statements. We received feedback, we analyzed the feedback, and the statements were refined accordingly. The second round of our online Delphi evaluation took place in the beginning of October, right before the Lipoedema World Congress in Potsdam. Statements again were refined according to the feedback and the responses received. Then a physical meeting took place during the Lipoedema World Congress in Potsdam. During this physical meeting, every single statement was discussed, not only in a sense of supportment of the statement, but also about the formulation. And the formulation was very, very complicated in the further process. So it took us quite a time to analyze the responses received and to incorporate the feedback to create the final Delphi statements that were voted on in mid-2024. Between April 15th and July 25th, 71 of the Lipoedema World Alliance founding members voted on these statements, and the final results were conducted into a scientific manuscript. So now briefly a few methodological aspects on our Delphi process. For each statement, we collected responses on 5 different points. First, is the statement clear? Binary answer, yes or no. Or we used the 5-point Likert scale to assess the level of agreement with the statement, or whether the statement should be included in the manuscript. We rated the level of evidence. And final question, again binary, yes or no, ask whether further research would be necessary for conclusive evaluation. Agreement with the statement was defined as a rating of either 4 or 5 on the Likert scale, and this threshold had to be met in at least 70% of all responses. Briefly, the results. In total, 71 of all founding members of the Lipoedema World Alliance participated in the evaluation process. 34 women, 37 men. Experts who originated from 19 countries or 5 continents. The professional background was diverse, so from general physicians, surgeons, and therapists, every profession was involved. The majority of our participants in round 3 had long-lasting experience in working or treating patients with lipedema. As presented in our lecture before, statements were developed on 8 different domains: definition and leading symptoms, pathophysiology, epidemiology, comorbidities and concomitant diseases, impact on quality of life and symptom burden, diagnostic approach, treatment modalities, and, very important, future directions. In total, 59 statements were included that reached the predefined agreement threshold of 70%. Of these 59 statements, 6 were particularly controversial, achieving approval ratings of only between 70 and 80%. The majority of our statements were clear and easy to understand. Agreement levels were quite high and recommended for inclusion. But on the other hand, for a vast majority of our statements, the level of supporting evidence was rated quite low, and additional evidence was recommended for many statements. And here an example on how it looked like in our final manuscript. lipedema is a chronic disease. This is the statement. For each statement, we reported on the 5 aspects that have been voted on. And as context, we created an expert panel comment, putting the ratings and the statement into the context of the current literature. Second example, the BMI that has always been discussed as an anthropometric measurement for lipedema patients. We defined that the BMI has only limited value in distinguishing between lipedema and obesity, and it's advisable to utilize the waist-to-height ratio to exclude or assess obesity. In the expert panel comment, we further highlighted that the BMI nevertheless should be reported in lipedema patients. For those interested in the publication, it's publicly available and online accessible on the website of Nature Communications. To stay in time, this is the first Delphi study providing internationally acceptable best practice recommendations on lipedema. For most of the statements, we achieved high level of consensus. Low level of evidence in several areas were identified, on the other hand, highlighting the need for further research and standardized reporting. And the proposal in our publication was the development of a standardized case report form that was part of a Lipedema Foundation-led project in the recent months that had been accepted for publication just 5 days ago and will be published very soon. This consensus paper must be seen as a living document. We already heard that that new scientific evidence emerges, and the consensus publication has to continuously update it based on this evidence. Still, this is an important step toward greater clarity and orientation for future healthcare policy and for researchers. And as promised, Lübeck is beautiful. It's always worth a visit. Thank you for your attention.
Thank you so much, Philip. That was a really wonderful summary of the way the process has taken place. And I think we're so lucky to have you in our lipedema community with your incredible surgical skills and your amazingly analytical brain making sense of it all. So thank you very, very much. We'd now like to move on to a presentation by Dr. Joanna Dudek, who's the assistant professor at the University of Warsaw in Poland. You can already see we're a very strong international community here and rely on so many different skills from different countries. I believe we're doing a presentation first. I'm not sure. Are you there, Joanna? Yes. Hello. I'll hand over to Joanna for a presentation on the psychological mechanisms and the impact of lipedema on the quality of life.
Hi, my name is Joanna Dudek, and I'm a professor at SWPS University in Warsaw, Poland. Today I want to talk about psychological mechanisms and the impact on quality of life of lipedema. I want to talk about this in the context of Lipedema World Alliance consensus, so I will also cite some statements from the consensus and show related research results, some theories that explain why those statements look like they look like. So let me start with the first one. Lipedema can negatively impact mental health and overall quality of life. I assume we can all agree on that. There is a lot of studies confirming that lipedema negatively affects quality of life. Here is a sample from my example of my studies. I conducted 2 studies on women. One was on women with lipedema from international group, and then women with lipedema from Poland. As you can see, those from international group are in blue, and from Poland are in orange. And you can notice that the quality of life is lower than the average for general population. for each scale. So not only physical health, but also psychological health, social relationships, and environment. As for the mental health, there are different measurements and different aspects of mental health that we can measure. So I want to show you some examples from my own research. So here is an example. We used appearance-related distress. We use scale to measure appearance-related distress. This is a scale to use visible differences in appearance and their impact on distress. As you can see, women with lipedema are in orange. As you can see, and they have high level of appearance-related distress. And that is a risk factor for both eating disorders and depression. So the next slide that I want to show you is from, again, my two studies on international group and women with lipedema from Poland, that we measured, where we measured depression symptoms severity. As you can see, more than 50% have moderate to severe symptoms of depression, which is highly concerning, as this might impact their quality of life and everyday functioning. And here is an example of the study that focused on disordered eating. The scores of women with lipedema are in orange. We measured different aspects or different symptoms, behaviors connected to disordered eating. And as you can see, they are much higher than in women in general population. So from those studies, we can tell that mental health of people with lipedema is affected. And that leads me to the next statement, which says that if present, psychological involvement might be caused by lipedema-related symptoms rather than being the cause of those symptoms. To explain that statement in detail, I would like to show you the model that explains quality of life. When we look at the quality of life, there is a number of different models that allow us to understand what affects quality of life. And here is the example of a model for health-related quality of life that is adjusted to patients with lipedema. As you can see, of course, the symptoms of the condition itself affect quality of life. So here we have pain, fatigue, but we can also have heaviness or swelling. There might be also some associated medical conditions that also affect quality of life. Those symptoms lead to differences or changes in functional status. So how the person functions with those symptoms. In lipedema, we have decreased mobility or difficulties within the area of mobility, and I will talk about it in a moment. But also I mentioned already appearance-related distress caused by the changes in the appearance that are visible to others. And finally, that can affect psychological functioning. So in some situations, it can lead to depression and anxiety eating disorders. And all of that affects quality of life or satisfaction with life. Now here we have two other components of the model, which are characteristics of environment. So here we know that there is a specific context in which lipedema exists. And this context is made up of different, I would say, difficulties that patients need to struggle with. So one is little knowledge about lipedema, not only in the healthcare system, but also in the general population, which in connection to weight stigma and often misdiagnosing or seeing lipedema as obesity leads to stigmatization or discrimination based on weight. This little knowledge also leads to delayed diagnosis. And I mentioned here being that this disease is kind of invisible in the system, meaning that it symptoms of lipedema are visible, but at the same time are invisible because they are misdiagnosed. There is delayed diagnosis, there is weight stigma, they are diagnosed as obesity or other conditions. And also one of the aspects of the environment that affect how patients with lipedema cope is the high cost of treatment and difficulties to get the treatment. And also the treatment itself is also kind of complicated and needs to be managed by different healthcare providers and is not a causal treatment. So all of that might affect how those symptoms in this context affect quality of life and psychological functioning. Of course, we also have characteristics of individuals, so how individual copes with those difficulties, and people differ, and depending on how they have different traits or different qualities of their behavior and psychological functioning. Of course, that might affect how they react to symptoms or how they react to stigmatization or delayed diagnosis and how they cope with the treatment of lipedema in the end. However, to sum up, what I want to talk about here is that the psychological functioning is rather an effect of the symptoms within the context and not the cause of symptoms, of lipedema symptoms. The next statement of the consensus says that missed or delayed diagnosis or management of lipedema negatively affects a patient's symptom burden, mental well-being, and overall quality of life. I assume this is not a surprise to you from what you know about lipedema already. But I wanted to talk a little bit more about those reasons. I already said about the lack of knowledge about lipedema that makes patients wait for the diagnosis, make patients don't know that they need to look for the diagnosis, and also delays getting the treatment. But it's also about weight stigma. So perceiving people with excessive fat tissue as kind of worse than those people who don't have excessive fat tissue, and also treating them as if the excessive fat tissue is the reason for all the health problems, for example. Another reason for the delayed diagnosis is also gender-related bias towards pain. There is a number of studies showing that when women report pain, it's treated differently than when men report pain. It's often attributed to emotional causes. Women are more often prescribed antidepressive medications or asked to go to psychotherapy when they report pain in comparison to men. And that sometimes might lead to delay in diagnosis because women stop reporting pain after being invalidated many times, or even start invalidating their own pain, like, oh, it is not really hurting me as much, or this is like a typical pain that I need to have. And therefore, if they do not report it, it's less likely that they will receive a diagnosis. And finally, there is the whole problem of a system where women often are sent first to psychotherapy and or psychiatric treatment instead of being diagnosed with chronic conditions, especially if they are not common ones. And how that affects patients' functioning. So there is a number of possible consequences that are mentioned already. So it affects mental well-being, overall quality of life. But first of all, it's increased symptom severity. If there is a delay in diagnosis, of course, symptoms might become more severe. For functioning, I mentioned functional status. So the longer you wait for the diagnosis, the more impact symptoms have on the functioning, on mobility, on the stress related to appearance, especially if a person doesn't know what's going on. if you think, for example, of a teenage person, and this teenage person starts to grow fat on their legs, doesn't know what's going on, what happens is that the person doesn't know that this is lipedema, so they start going on different diets, trying to lose weight, but it doesn't work. So typically what happens is that people start thinking about themselves in a very negative way, like there is something wrong with me, I'm not doing this diet good enough, whereas it is not the diet itself, but the problem is with the fact that the person had lipedema and was not diagnosed on time. So this leads me to talk about the final thing here, so psychological consequences. So it might affect mood, it might affect self-esteem. What we think about ourselves is based upon mistaken assumptions, like people start to think I'm weak because the diet didn't work, whereas the fact is that the diet didn't work because this is lipedema and this diet would never work on lipedema. If that lasts too long, it can also lead to avoidance related with appearance-related distress, and avoidance, we know that can lead to depression, anxiety, different disorders. And also I mentioned self-invalidation. So if someone feels something and is often said that this is too much, they are exaggerating, that it's not a real thing, they start invalidating their own symptoms, which makes the diagnosis even more difficult later on. And the next LWA statement says that missed or delayed diagnosis or management of lipedema increases the cost burden for patients and the healthcare system. And obviously, this is a natural consequence of everything that I said so far. So I just want to show you, maybe I will not talk more about this, but I will just show you the result of one of the studies that we conducted. Here you can see what is the maximal function of lower extremities. So this measures the level of mobility. If you have 100, it means that you can do everything that a person from general population without any chronic conditions related to legs is able to do. So walk a couple of steps, walk on the stairs, etc., etc. As you can see, a lot of our participants had less than 50% of maximal function of lower extremities, and that is due to the prolonged time that they had to get the diagnosis and the progression of symptoms that progressed so much that affected their mobility. And of course, both mobility and loss of mobility and depression, these create a lot of costs for healthcare system, not only for the patients, of course, but also for the healthcare system, as people tend to stay at home, do less and less, and their health is getting worse. Therefore, in the consensus, we also have two very important recommendations: psychological and social support, addressing body image issues, mental well-being, and coping strategies can be important to address the symptom burden of patients living with lipedema. I guess this, after what I said so far, it's quite obvious that we need to address psychological functioning to support people with lipedema to cope with the symptoms. And finally, this is something that we are doing here, being here right now, raising awareness about lipedema within the medical community and wider society is essential to reduce misdiagnosis and stigma. And I'm very glad that I could be a part of this. I can be a part of this event and also together with you raise awareness about lipedema. Thank you very much.
Thank you so much, Joanna. You are an outstanding example of somebody who became interested in lipedema as a student and now you are a highly qualified medical researcher in a wonderful university. So I do hope many, many more people follow your path. I'd now like to introduce somebody who's very dear to me and does a lot for Lipoedema UK. She's a patient and has a great deal of experience from her and her daughter's experiences. I'd like to hand over to Sandra Slaughter to tell us all about her lipedema journey.
Thank you, Sherry. It's lovely to be with you all today. So yeah, I'm here today not just as a woman living with lipedema, but also as a daughter and a mother, because this isn't just my story, it's a familial story. And it's also a story about understanding how the absence of it can shape a life. For over 40 years, I believed the shape of my body was my fault, but this didn't begin in adulthood. Around the age of 12, my dad took me to see a consultant at St. Thomas's Hospital. His opinion that it was simply a different form of puppy fat and that I would grow out of it. Of course, I never did. And from that point on, I kept asking every medical professional I stumbled across, every nurse, every GP, every midwife I encountered over the years, why are my legs like this? And no one had an answer. So I created my own, that it was me, that I was doing something wrong. From a young age, there were many messages. My mum didn't want me to end up with legs like hers, so I was encouraged to eat differently, while she herself lived with restriction. And then there were comments. I'm still haunted by words like tree trunk legs, sacks of potatoes. I remember standing at a tennis club in the required skirt and hearing one of the dads say, I really don't think we need to see legs like that here. Those moments stay with you. They shape how you see yourself. I even felt embarrassed and sorry for the medical professionals that had to look at or sometimes touch my legs. I've spent hundreds of pounds on diets, exercise programs, anything that promised change. None of it worked. I avoided social situations, struggled to find clothes that fitted, and stopped doing the things I loved, like tennis, netball, and horse riding. At one point, I even had to change my job because I couldn't stand on my legs all day. They were too painful. Even holidays felt overwhelming. I remember packing in tears, trying to find clothes that would cover my legs. My legs didn't just affect how I looked, they also affected how I lived. They affected my relationships. And like so many women, I wasn't questioned. I wasn't diagnosed. I was simply told, it's just fat. You need to eat less. In 2010, I lost 5.5 stone. I decided to stop dieting. And instead, as an executive coach at the time, I applied my coaching skills to myself. Work that later became my own wellbeing programs, supporting others in their health and with their resilience. But at the time, I had no idea I was living with lipedema. Yet even after that weight loss, my legs didn't change. That confusion continued to stay with me for years, until one moment when unexpectedly a therapist asked me, have you ever heard of lipedema? That moment changed everything. There was shock, grief, anger, disbelief, denial, and ultimately sadness, because I realized something profound. For decades, I had been living with a condition I didn't know existed and blaming myself for it. What started to shift wasn't just my understanding, it was my relationship with myself, and as I became aware of deep-rooted limiting belief systems. But the story doesn't end with me. I have 2 daughters, Charlotte and Georgina. They also have lipedema. And when the 3 of us received our diagnoses, something else became very clear. My mum, who was 80 at the time, had it too. She had been on a strict diet for most of her life, and yet it had never changed the shape or size of her legs. She had struggled to find trousers to fit and had very painful legs. Then the realization. My mum is one of 8 sisters. Every single one of them showed signs of lipedema. And their mum, my nan, clearly had it too. I have also a first cousin who has been diagnosed recently as well. So this is not just my story. This is a lineage, a pattern that has lived quietly through generations of women, unseen, unrecognised, and misunderstood. And what that means is this. For decades, these women lived believing their body shapes were their fault. They lacked discipline, that they had failed. They lived in pain, in discomfort and embarrassment. Like me, my mum and my daughters, when in truth they were living with a condition no one had named for them. But here's where something begins to change. Thankfully, both my daughters were diagnosed early, and our eldest daughter's response was something I will never forget. She felt relief that she hadn't caused this, relief that her body wasn't a failure and she wasn't an enigma. For me, those beliefs have been lived for decades. Just imagine that difference. One generation grows up believing they are the problem, and the next grows up knowing they are not. And yet there are still fears about the future, about progression, and until recently, something else I hadn't fully realised. Fears about my daughters having children of their own. My daughter Georgina discovered she was expecting a baby the year before last, unbeknown to me at the time. She felt she urgently needed to find out the gender of her baby for fear of it being a girl. Charlotte later shared that she feels exactly the same responsibility. Because lipedema doesn't just live in the body, it lives in the questions we carry forward in all ways. So if I may, what would I gently invite you to take from me and my family's lived experience? A deeper awareness that lipedema is not always visible in the way we expect, and that its impact goes far beyond appearance. An understanding that this can be a familial, generational condition, often missed, often misunderstood. And perhaps most importantly, an awareness of how powerful our role is, because the words we use, the questions asked, and the curiosity we bring can be the moment that shifts something for someone, from shame to understanding, from self-blame to compassion. We cannot change what previous generations didn't know, but we can absolutely change what this generation experiences. I now have some slides that I would like to share. First, I'm just going to go through these very quickly. Just wanted to share some of these pictures with you. Myself here with the girls on a beach. I can't remember when, but what is always classic in pictures, in family pictures, that you can see the girls are either covering my legs up or I've got a cover on, in this case a sarong. The girls here in this particular point, we can see with quite slim legs, but we can see my lipedema leg peeping out from the sarong. The second slide, if I may, again, another holiday with the girls in front of me. I'm going to be focusing a little bit more on Georgina in these photos, our youngest daughter shown here. She had what we called Betty's spaghetti legs. There was a doll at the time called Betty's Spaghetti because her legs were like little sticks of spaghetti. And I was really relieved that she showed a different body shape to her sister Charlotte. But unfortunately, that wasn't to be. So if I may have the next slide. Thank you. A family trip to Disneyland in Paris with my late father and mother. And we can see Georgina here, Charlotte in front of me. My mum here, very pleased to be in trousers at this point from a generational point of view, always in dresses and skirts until more recent times. Really struggling, as always, with holidays like myself with this. So many steps, so much heat and pain. she would frequently have to go back to the room to rest her legs, suffering with swelling and pain. And the next slide, please, if I may. Moving on to the girls on holidays, beginning to see the shape change in their legs. And the next one, please. Here, Georgina. Georgina started puberty around the age of 9, and literally overnight, her lower body limbs started changing before our eyes. And the next one, please. And we can see here with Georgina here, a group of friends after school, very clear, similar age, similar heights, the differences in the leg presentations. And the next one, please. And we can see here, Georgina here, again with some friends, and showing, as we can see with the classic signs of lipedema, but also out of the 3 of us, Charlotte, Georgina and myself, Georgina really being impacted by the condition, sadly. And the next slide, if I may, please. So the girls have kindly shared just 2 of their pre and post liposuction operations. This is Charlotte, and then please, Georgina, the next slide, if I may. Showing Georgina here at 17 years of age. From our doctor's point of view, she was the youngest patient that she had operated on, and we can see the results of that surgery before you here. And the next slide, if I may, a very rare picture. She discovered this clearing my parents' house, of my mother without any clothes on. That's how she appeared all through my life. This was when she was quite young. But again, very subtle signs here now of lipedema. And the next slide, I've only got a couple more to go. My nanny Bert, as we called her, she had 11 children. And always covered up, but we can get a sight of her legs. We could always, of course, hug her, but never touch her legs because they were far too painful. And last but not least now, a picture of 4 of my aunts with my nan. I don't know when this picture was, please forgive the quality. But we can see here with 4 of the 8 of my aunts, the different stages and signs of lipedema in our family. Thank you very much for listening.
Thank you so much, Sandra. Your story never ceases to uplift me and distress me. And thank you so much for sharing it. And thank you to your daughters. It just tells us so much about what it's like to have lipedema.
Thank you, Sherry.
Thank you so much. Now we're going to move to Lorraine Nesbitt, who's the clinical manager at Daylong Direct and has information on insights from a patient and clinical survey on the challenges and needs of patients with lipedema. This is quite unique that Lorraine put together this survey on both perspectives. So thank you, Lorraine. I'll hand over to you to tell us all about the work you did and the survey results.
No problem. I'll just share my screen. So I'm hoping everyone can see my screen now. So thank you very much for inviting me to share, as Cherie said, some of our clinical insights into the challenges and needs of patients living with lipedema. So why we surveyed both, we wanted to look at the lived experience gap. We wanted to understand more about the challenges of living with the condition, to get an understanding of what other requirements patients may need. And then we really wanted to get an understanding of the awareness and the educational needs of clinicians to really try and kind of bridge that gap between this often unrecognised and undiagnosed conditions, as highlighted exclusively and extensively in our previous talks. So just to kind of give an introduction to both of the surveys. So this is the methodology for the patient survey. So this was distributed by Lipoedema UK to its members. It was a 44 multiple choice question. This was anonymised. We got 153 responses. The largest age group was between 55 and 64, but we do have a spread of demographics. The largest response within the southeast of England, but we do have participants from the UK, Northern Ireland, England, and Scotland and Wales. Then if we just look at the clinical respondents in the survey that we did here, so again, anonymous feedback. This was distributed by the Journal of Community Nursing to their database of healthcare professionals. This was a 12 survey questions. We got 950 responses. This was an average response rate of 68%. Anything above 50% is generally deemed as very strong and very good. So we were really pleased that people really engaged with the survey. Again, the largest region was England, but we do have, again, from England, Scotland, Wales and Northern Ireland. And not surprisingly, as this is the Journal of Community Nursing's database, most of the feedback here we have is from practice nurses and GPs, community setting, but we did have a few GPs and in private clinics as well. So we do know there's limitations to surveys. As we said, it was distributed online, which does limit participation to individuals who are computer literate. The patient survey was distributed by Lipoedema UK, so that means only those within their database had access, which may not reflect everything in the wider population, but it does give us really good feedback from patients living and coping with the disease at present. And as we said, the clinician survey was shared through the JCN, which does restrict participation to its members, so we may not have caught as much information for GPs and some of the wider healthcare practitioners. So I'm going to start with the patient feedback today, and don't worry, I know we have 20 minutes, and although I can talk pretty fast as a Scottish person, I'm not going to go through all 44 answers. I'm just going to give you some of the highlights from the patient and the clinical feedback today. So I'm going to start with some diagnosis. So this is actually in line with what we see in the 2020 Lipoedema survey that was done before. The patients are still taking, on average, 45% to get 10 years to get diagnosed. So we know that this is still quite a delay in recognising and diagnosing the disease. And when we listen to what Anne talked about in our opening talk, when we think about taking back control and early symptom management, any delay in diagnosis is definitely a disadvantage to the patients. It means they're not getting support with appropriate care and they're managing their condition alone. And as Sherry alluded to in our opening statement, we know that a lot of people end up looking at social media and other places that they maybe shouldn't for that information. So a delay in diagnosis definitely causes extra problems. We then asked about access to specialist care. So this is the patient. So we see if we look at very difficult, or never seen a specialist, 3/4 of the patients have found it really difficult to access any sort of care at all. And 17.2% have never seen a specialist. So when we look at that, when we see how difficult it is for them to do it, and we know that they're self-managing in this time, if they've never seen a specialist, if they've managed to access one delayed, they're not getting the right support. It's not surprising that when we ask them about how unsatisfied or how satisfied they are with lipoedema services, nearly 50% say that they're not. So when we think about these results, we wanted to also ask them about how challenging it was to get to see a specialist once they were referred, because we know that socially, economically, patients can be disadvantaged with a chronic condition. They have to do a lot of more clinic visits. They're regularly seeing clinicians, travelling to appointments, whether that be for therapy, compression, or maybe manual lymphatic drainage. So we wanted to see if they were at a disadvantage as well about where their clinics were. So about 30% of the patients said they travelled between 5 and 20 miles to access their services once they found it. So that's probably in line in what we see from a lot of other conditions and your general access to hospitals and clinics. There's only a small proportion of patients that came back and said they had travelled over 100 miles to access service. But a lot of this will be skewed by the fact that some people have travelled abroad. We see this a lot now, people going abroad to access liposuction, non-cosmetic. So those are those patients that have travelled a little bit further to access services. But what we also see when we ask them about living with the condition, about 33% of the patients that responded to this survey had also been diagnosed with lymphoedema. So we know this is a complex disease that needs more than focus on just lipedema alone. It highlights that need for that holistic, accessible approach to lipedema care for additional symptom management. It's not just the lipedema alone that these patients need support with. So then we ask patients about their care. So as we know, a lot of patients are managing their symptoms at home, they're self-managing. And when we ask patients about how long they were physically spending, about 30% of them were spending between 6 to 20 hours a week managing a condition. This is very time consuming if you have a family and a full-time job, finding these extra hours in the week, and has a massive impact on their quality of life. Then we asked about support what people who maybe need additional carers or maybe family to support to help manage the condition. This maybe be from skin care, or maybe applying compression, dressings, things like that go along with it. So 21% were needing daily support for their care. So when we think about this as carers costs, some people are self-funding this from care. Some people are obviously have accessing government care for this, but also a lot of this is done by friends and family. But if you're having daily support with this, it also has a bigger impact on quality of life. If you're having to stay at home for daily carer visits, you become almost what we call nurse locked. You're having to stay at home and wait for somebody to visit you. So that means you can't go around living your daily life as free and frequently as you would like. It makes travel a challenge because you always need somebody with you. So it's not surprising that when we ask about services and support for lipedema, nearly 50% are very unsatisfied from what they exists out there. And as we mentioned, and Sarah alluded to this in our talk about pain and standing on our legs at work and how that's impacted our working life, we asked again about the financial burden of living with a chronic disease. So we know that people that have chronic disease are already socially and economically impacted, and we wanted to ask this demographic of patients and people living with the disease, how it was impacting them financially as well. Because it's not just about living with a condition itself, it takes over a lot of their life. So 58% of patients came back and said they spend up to £100 a month managing their condition. So this is on non-compression costs. This is on skincare, dressings and therapy. This is before they start buying garments if they're not getting them prescribed on prescription. So they're already out of pocket when buying extra things. Also, if they're waiting a long time to be diagnosed or they've not got access to specialist care, my question would be here, are they purchasing the appropriate things as well? Are they using things that maybe aren't helping their condition through misinformation on social media? So they're out of pocket already, but maybe out of pocket on things that aren't suitable for their disease. And then we asked specifically about surgery because we do see a rise of this. We see a lot of people going abroad now to get non-cosmetic liposurgery. So we asked about the financial burden of having to pay for their own surgery. So of the patients who had a non-cosmetic surgery and travelled abroad, there was 93% of them. And then we look and ask for the breakdown of cost. 38% had spent between £10,000 and £20,000, with a whopping 28% have spent over £20,000 trying to have non-cosmetic liposuction to help their condition. So this is a significant burden financially, and this is also sometimes in repeat visits. So that includes the surgery itself and the travel costs to go over and see the clinics. We then asked about an impact on their income generally from working life. So over 50%, so 53% had responded that lipedema has had an impact on their income. And this is due to multiple things. So reduced hours, not being able just to work as long, having to take additional sick time, some just unable to do their job at all because of pain, or just unable to do a job that they actually wanted because their condition does not allow them. 20% have had to reduce hours of work due to lipedema, again, due to pain, being unable to stand. So this has an impact on them financially, but also needing additional time off at work to go to clinic visits, to go to therapy when they've accessed it. And also we see that 13% have required to change jobs altogether or unable to attend work due to their condition or do the job they want. In some cases, some of the comments were, I simply do not fit into the uniform that the work requires me to do. I can't do that job. So we know that they are taking on a hefty burden financially and unable to, and having that social economic impact on them. So we asked about treatment and management of her condition. So I know there's a talk later on compression, and we know that most patients have been prescribed or bought their own compression in the form of made-to-measure wraps, wrap systems or off-the-shelf garments. And we see a lot of this, once I start looking at one thing in social media, within hours, I'm getting 5,000 adverts for different compression garments, which aren't always medically graded. So a lot of patients are buying their own. A lot of patients buy additional ones because they're meant to wear them daily. They don't want to launder them. So they always want one to wear, one to wash, or want choice. They are consumers. They are people that want to have a bit of variety in their clothing. So a lot of people are buying additional garments. Around 47% of them are wearing their compression daily. So we do know that this this should be higher, and we do know there's an issue with concordance and compliance, and some of that may just be down to the fact that they have bought the wrong garments that don't fit them and don't feel comfortable. So we only see 45% of our patients saying that they found compression effective or very effective, but it's mainly about managing symptoms. But when we asked them about when they did have compression and when they were into a treatment regime, how did they find the follow-up and their access to care? And we see 56% had no advice on how to apply. And we know within the compression community that getting compression to fit properly and also to wear it properly is really crucial. Also, we know about application aids. I was with some patients a few weeks ago that their husband was helping them physically put them on and was using rubber gloves from the kitchen so they could get some grip. They didn't realise that application aids were something that was even available to them. So it's not just about giving them the garments or giving them what they need to wear at the time. It's also to look at what else that patient may struggle with, maybe their dexterity or their mobility, and actually need some additional support. And also a little bit of advice on how to wash or replace garments to make sure that the correct compression lasts, because these garments don't last a lifetime. They will eventually need changing, and these patients should be reassessed. So they really need that follow-up advice to make sure that they know how to look after their garments and themselves. So again, this leads to having an unsatisfied score with current treatments. So I just put this in here for a little bit of information. This isn't on lipedema, but this is on compression studies in general and the reasons for patients stop wearing their compression stockings, which will have some resonance in what we're talking about today. And one of the biggest reasons for compliance in patients not wearing their compression is a misunderstanding between patients, clinicians and pharmacists, not having enough information about how and when to use them. And as we say, when they don't get that follow-up or don't get that additional guidance, it's not surprising that some people don't know how to or when to use them. But putting them on and off is definitely one of the second biggest reasons why people don't continue to wear their compression. So really having that conversation about how to manage that there are extra things there to help them is something that's really crucial. So I'm just going to move on to the HCP feedback now. So we asked a lot about education and awareness, and what was nice to see that 90% of the clinicians that we surveyed had heard of lipoedema. So this gave us some great feedback. They were like, we are getting the word out there. The word is spreading. Sheree and her team are doing a fantastic job at doing it. But then what we see is after this is, although they may have heard of the condition, they haven't received any formal training in it. So the majority know about the condition, but haven't received any training on seeing the signs, symptoms, or diagnosis of disease. So when we ask them about their confidence, if they saw patients, about half thought they were confident or very confident in recognising signs and symptoms. The other half were not all confident, unsure. So it's a very, very mixed bag out there. And when you dive into the data, the people that are more confident are those that work in the lymphoedema area, because they are seeing a lot of their patients in their clinics. So it's not surprising that they are much more confident than other practice nurses. So we did also leave an open text response box to let us have extra comments here to gather some additional feedback that we may have missed in our questioning, because we'd love to send out a 200-page question and survey, but the chances of somebody opening that and answering them all are slim to none. So we did ask for more feedback, and approximately about 200 of the responses that we got from the clinicians were referring to training and education needs for themselves and for GPs, because GPs are where most patients' journey will start. So they do understand they need an awareness and training, and hopefully after a day like today, this is something that will really help them with that. But as well as asking for more training and education, they also access to availability to specialist services. For the nutrition services, mental health support, as the other talks have alluded to today, it's good to see that they want that. And also, as they said, more support on compression from companies themselves, understanding what's available for their patients. We then asked about referrals in their area. Do you have specialist areas? We had an overwhelming no or I don't know. So people do challenge to know that once they've got recognised lipedema, where do they send these patients? We asked them if patients were allowed to self-refer in their area. The overwhelming response here was no or unsure. But also what was interesting in these questions around referral is actually the response rate dropped off quite significantly, which kind of indicates to me that there is definitely an uncertainty about where to send patients for help. But when we did ask about when they did have somewhere to refer, the referral times were not extensive. Between most patients had 1 to 3 months, so that's quite nice to know that they're not waiting along. But we do know that some people did wait over a year. But this will be in an area where the just services don't exist. We then asked about diagnosis and what challenges do you face when you diagnose lipedema. So they were allowed to pick multiple choices here. So with this is why we see a lot of high responses. But not surprisingly, what we kind of thought, based on the additional ones, was lack of training on the subject. They're unsure of the signs and symptoms to relate to lipedema. And we know when we look at the consensus is that under-recognising and undiagnosed leads to worse outcomes. So being able to give more training, highlighting those signs and symptoms and really raising that knowledge across healthcare colleagues is really crucial to get patients better outcomes. We asked about treatment and management, and surprisingly, compression came out top, because thankfully when they see the patients, that compression is something that should be offered. But what we did say here was the next one was lifestyle modification, diet and exercise. And as Anne alluded to in her talk, we do know that a lot of patients are simply told to lose weight. So although diet and exercise is something that we all need to stay a bit healthy, it's not the answer in all cases for this condition. So it shouldn't just be the first line. There are other things that, like psychological support that these patients really need. And I really just wanted to bring it back to the patients here, going off the basis of asking for help there. We had over 300 responses from the patients in the comment section, and I will admit it was quite a heartbreaking read in a lot of cases. A lot of people talked about the fat shaming that they receive when they met their clinicians, don't see friends anymore, talked a lot about the pain, a lot about their confidence and self-image, and really, highlighting the problems that it had on their mental health. So although lifestyle management may be something that's discussed, it's really a lack of awareness around the disease. It's really about clinicians acknowledging that and knowing where to refer them, and not always bringing it back to lifestyle and diet. There are other reasons that things are going wrong, and to really think about how you're speaking to patients when they approach the subject, because the patients really feel that some of the clinicians don't acknowledge their lipedema. They want to hide away from the world. So there really is a need for more awareness and support in this area. And if you access the paper, a lot of the patient comments are in there. So just to kind of bring us back to the end here, from what we've seen in the other papers and what our survey kind of highlights today, that it's still underdiagnosed today. There's a limited understanding within some of the healthcare areas. There is definitely a need to manage and refer, and definitely a need for improved understanding of disease, that we need to get delayed diagnoses, the diagnoses be brought forward to reduce that 10 years wait, because we know that there's low mental health and delayed access to treatment leads to poorer outcomes. So just in conclusion today, as we said, increased awareness, better training of HCPs was one of the biggest themes that came out of the survey, more access to treatment. HCPs want better diagnostic tools and want access and support with specialised treatment, and hopefully addressing these challenges can pave the way for this. But ultimately, compassion is really what is needed for an often misunderstood condition. So thank you for listening today, and I will hand you back to the team.
Thank you so much, Lorraine. That was a really wonderful overview from the perspective of patients as patients and healthcare professionals who are doing their best to give them advice. What we're going to do now is have a panel discussion on some of the questions that have come up and some of the topics. So we've got Sandra, I can see Joanna there. Is Philip still with us? I know sometimes it's difficult for everybody. Yes, well done, Philip, you're still there. And Anne, are you still with us? Can you join the panel discussion, please? Lovely to see you all, and thank you so much for a really interesting range of topics. We've had a lot of quite deep personal questions in our chat box, some of which have been answered in detail by our team. But I think the overall theme that's come out of it for me is that patients have a lot of very complicated questions, and they do see ways of associating other conditions other than lymphedema and obesity with the symptoms they have. And as they get into more medical, maybe terminology and knowledge, they do have other diagnosis. And I think from my perspective, maybe the lesson of these questions is we talk about lipedema, lymphedema, and obesity. Those are the three we mention over and over again. But there are all these other conditions which people believe, and we are seeing research coming out. Philip, can I start with you from your research aspect and seeing so many patients through surgery and your clinics? Would you have any indication of other conditions which are prevalent amongst patients with lipedema?
Yeah, that's quite an interesting question, actually. And I would love to give a conclusive answer, but honestly, the data is not very convincing that other concomitant diseases are associated with lipedema. So I read in the chat about Ehlers-Danlos syndrome, and I do see patients with hypermobility, but not as much as we read in the publications in the US, for example. Then I read in the chat about, let me check, vitamin D. Vitamin D deficiency. There is one or two publications out correlating vitamin D levels of lipedema patients with healthy population, but the overall case number is quite low. So arguing that lipedema might be the cause of vitamin D deficiency is very speculative nowadays. Nevertheless, this is an issue in Northern Europe, especially. So then I read about PCOS or PMOS. This is something that I find very interesting, polycystic ovarian syndrome. I would like to have a collaboration partner from the gynecologist to have a deeper look into this topic. But at the moment, we do not have any conclusive data of a shared pathophysiological pathway. So, in summary, I do see a variety of concomitant diseases. There are publications out highlighting this fact that the majority of lipedema patients do not only suffer from one condition, but a causal relationship, a pathophysiological cause that connects different concomitant diseases with lipedema. We do not have convincing data, even for very, very often observed thyroid diseases in lipedema patients. So this is something that we will have a look into, but at the moment, we indeed treat every single disease as a separate disease.
Thank you, Philip. I think that's another indication of the lack of research into the whole condition. So, Anne, can you add to this debate about any repeat patterns you see in patients or concerns that they have about other conditions?
Thanks, Shari. Yes, I mean, I think anecdotally, myself and many of my clinical colleagues will see very often hypermobility, thyroid issues, and Dr. Samaro has written an interesting paper that was from that was published last year, which I was going to put in the question and answer chat. I was just looking for it just now. But I think we just don't have good level epidemiology studies to look into this. It's too early. But I suspect we will see these links, but we just don't have the evidence.
Okay, I'm afraid we're going to have to draw to a close because we've got such limited time in our programme. I think if I was to add anything at all at the moment, I would say to patients, we've got one particularly from a newly diagnosed nurse, she's saying, what what can she do as an individual, I would say don't lose your self-confidence. Don't lose your self-belief in that you can beat this condition, that there are people, wonderful, wonderful people out there who can help you. It is a long, difficult journey sometimes, as Guido's just said, especially in the UK, to find them. But please join in any events like this and self-educate yourself. Thank you, Sandra, for your wonderful illustration of a family who's really done that and transformed, I know, your daughters' lives from when I first knew them through their journey, and your nurturing of your girls through that, and your understanding of what it feels like. And Joanna, thank you so much for your research on the psychological aspects. You have led that in a world sense and actually highlighted things scientifically. And Lorraine, thank you for your work as well. So thank you very much, everybody, for taking part in this session. We're now going to move on to the second part of our programme, which is going to be chaired by Chris Jones, one of my fellow trustees at Lipoedema UK. Thank you so much, everybody. And over to Chris.
Hello. Hi, good afternoon, everybody. I'd just like to introduce Rodri Harris, who's also going to co-chair this session with me this afternoon. Rodri's clinical lead for lymphedema at Accelerate, and also a nurse advisor for Lipoedema UK. So that's been a fantastic first session, really interesting speakers and sharing of such personal insights. So session 2 is on management of lipedema, and I'm delighted to introduce for our first speaker, Sarah Percival Mills. She's a clinical nurse advisor for Lipoedema UK for over 10 years and also a trustee for the charity since 2022. Sarah's currently the lead for the North Essex Lymphoedema Service and has been influential in working through commissioners in securing funding to see lipedema patients. So without further ado, I'd like to introduce her session, which is integrating self-management and multidisciplinary care.
Thank you very much, Chris and Rodri. And I'm not quite sure how to follow our first panel of speakers this afternoon. They've been absolutely fantastic and said some of what I was going to say for me. So thank you for that, but I will keep it there. So bear with me while I see if I can get my PowerPoint to work. It has been one of those days. So yes, thank you very much for joining me this afternoon. This is just an overview about self-management and what we can do and how we can integrate that with the MDT, which is a really important thing to do in that respect. So currently, it may well be, as Lorraine said, that patients will go through a lengthy period of time before they get a diagnosis of lipedema from their GP or from another health professional. And certainly we noted in the big survey in 2014 that only 9% of patients were diagnosed by their GP on a first visit. Sometimes it took multiple visits. They did their own research and they took their own information into the GP and said, this is what I think I've got. Quite often they said this is from social media, and there is the risk then of them picking up inaccurate information as well. Individuals are then referred to lymphedema clinics if they have a lymphedema clinic in their area, but unfortunately many individuals don't actually have the benefit of being able to see somebody who's been trained in lipedema, and in many cases the NHS lymphedema clinics are not able to see lipedema patients because they're not funded for it. This is a huge issue, and certainly in my area we had to fight tooth and nail to be able to get funding to see lipedema patients. We can now see them, but only if they have an approved individual funding request. And up until a few years ago, there was very limited training for GPs or health professionals on lipedema. Again, the work of Lipoedema UK has set up with the Royal College of GPs an online training module, and this is available to GPs and other health professionals. There is also now some specialist clinical training on lipedema, which is available to MLD massage therapists and for lymphedema therapists as well. So things are certainly improving. However, once they've got the diagnosis, it's really important then to explain to the patient when you see them exactly what is involved with lipedema management. And self-management is key. This is a chronic and currently incurable condition, so they need to have the skills to be able to manage this on a day-to-day basis. Importantly for us is to give some level of education about what lipedema is and what its causes are, to discuss with people the fact there may be a family link, there may be other people within their bigger family circle who have it. It can miss generations. It might be a grandmother, it might be a great aunt. Just to discuss what lipedema is and then have an idea of how it's impacting on that patient. We will discuss things like daily routine skincare, body brushing, look at encouraging exercise and physical activity, what works best for them. We know it's not a one size fits all. Some people like swimming, some people like walking, some people like yoga, things like that. We will teach self-massage techniques, look to fit compression garments to support the limb, discuss dietary changes. Some people, a low inflammation diet is exactly what they need, and sometimes it's weight management and referring on to bariatric services. However, this isn't always straightforward. As we have discussed and has been said beforehand, there is multifaceted elements to lipedema, and it can be linked with comorbidities. The fantastic Delphi document has really given us an insight as to what professionals consider to be important when it comes to the definition and management of lipedema. And certainly on management, they linked on that lipedema may be associated with other comorbidities, hypothyroidism, connective tissue disorders, obesity, and poor mental health. Psychological and social support is also needed to address body issues and other things they may experience like anxiety and depression. And tailored exercises are needed to help maintain mobility and address the symptoms that can be related with that. It's not that straightforward, though, to get self-management, as we said. Sometimes we have to sort of look at the bigger picture, and this involves involving the MDT. The Delphi consensus paper also stated that comprehensive disease management requires an MDT approach to include physicians, physical therapists, and mental health professionals, and there was a 96.7% agreement with this. A higher number of 98.3% agreed that raising awareness about lipedema within the medical community and wider society is essential to reduce misdiagnosis and stigma. And again, active self-management can help control lipedema-related symptoms, again scored very, very highly in the consensus. So ideally, we should be looking at collaborative care as a gold standard for managing lipedema. Healthcare professionals should be encouraged to work with each other and the individual concerned to provide a solid foundation of consistently supportive care to manage not only the physical and psychological impact of lipedema, but the wider impact it has on that individual and also their family as well. So the multidisciplinary approach can add a number of things. You have many heads with different experiences with a wider skill base, and we can all work together to look at this multifaceted need that each person has. It isn't one size fits all. We need to work with them to identify the issues that are pertinent to them and then identify strategies where we can help to look with symptom control and symptom reduction, the psychosocial support they may need, and look to prevent disease progression or prevention. So that would be things like looking at whether there's an obesity element to it or whether possibly it could develop into lymphedema as well, which can happen with some patients. It can also enable us to look at appropriate assessment and referral pathways when we have individuals who've got really complex presentations sometimes. Again, it's looking at that holistic care for the person. So what should the MDT do? Rather than just look at, well, we can do this bit and we can do that bit. Ideally, we should work together and take a holistic, cohesive approach. Listen to the individual and treat them as such. Work together to develop this comprehensive, personalised care plan and review it at regular basis. So not just think, well, you've got this, that's going to be fine in 6 months' time or 6 years' time. Lipedema changes, as we've discussed already, or has been discussed already, hormonal changes, life changes can also have an impact on it. And we need to be flexible to change with that and change the work we do with our patients accordingly. We need to be able to provide education on self-management techniques, the things like the skincare, exercises, elevation, compression garments, but also teach and demonstrate practical tools the individual can use. And that could be things like relaxation, to help with anxiety. We might be looking at simple lymphatic drainage to help with the self-massage technique as well. So we can support and encourage the individual to take ownership of their condition as they understand it, and then be able to engage with self-management. The MDT should also be able to link in and refer to other specialists. So if somebody does have more complex needs, for example, if they do have hypermobility, of being able to refer on to a musculoskeletal specialist. So by having an MDT approach, this can have a real impact, a positive impact on lipedema self-management. I do apologize. So we can look at, by giving individuals information, we can empower them and their skill making decisions. They can become more adept in making informed choices, action plans, being involved in their care planning. This can help also support lifestyle changes. By providing psychosocial support, we can look to identify and support any mental health issues they may have. Anxiety, depression, low body image, they're very common things that I hear a lot from our patients with lipedema. And this in turn can help support their quality of life and look to improve it. A coordinated MDT approach will help to ensure the provision of holistic care, and that's involving other professionals who need to have an impact on this, and that might be whether it is a lymphoedema specialist or clinic, whether it's a vascular surgeon or whether it's a bariatric surgeon, or actually going on for specialist support with regards to counselling or psychosocial interventions such as CBT. And this should help to work with the patient to reduce their symptoms or the progression of lipedema in that respect. The main thing is a continuity of care and support will help to stop patients feel so isolated, and this is something, again, I hear very commonly and has been mentioned before. People who have lipedema often feel like they're living on an island. They feel they're alone. Nobody else understands their condition. And sadly, they're not alone. But what we can do by working together with an MDT and actually encouraging the skill bases and the knowledge of other health professionals, we can stop these people from feeling isolated and not supported at all. So suggested MDT members. This is not an exhaustive list by all means. There are a number of people. Probably the first people that will be involved will be GPs or primary care health professionals, looking to involve lymphoedema therapists, lipedema therapists, clinics, dietitians, nutritionists, weight management, bariatric services, physiotherapists, MSK specialists, occupational therapists, podiatrists, psychologists, and counsellors, to look at all the different things that impact on lipedema. It's not just the clinical presentation of the body shape, it's how it affects them. It's things like gait analysis, what issues they are having with their mental health, what do they need nutritional advice, do they need advice and support on doing the right exercises for them that's not going to cause any further damage to themselves physically. So it's really important that we have this whole approach and get everyone involved. And there are lots of other people I know who probably are involved or should be involved, but it will depend on the individual. So it's, again, very much not one size fits all, and we need to make sure that we do take a very individualized approach to supporting our patients. So how do we achieve this? Well, the Delphi report has provided a framework and identified that a lot of work still needs to be done to achieve integration and to reduce the health inequalities that we do see with lipedema patients. However, I think by looking at education of the wider health community in both primary and secondary care, to recognise that lipedema is a health condition and it isn't just obesity or just a fat problem. This is something that I still hear, that patients will come in on their initial assessment and they've been told by somebody else within healthcare they're fat, lose some weight. It was mentioned earlier on, this is still quite common, and this is something we need to address. It is interesting to note that on the television in England, there's recently been some advertisement campaigns about obesity being a health issue. I think we should be working on the basis to actually get lipedema recognised as being a health issue and not just a fat issue. I think the Delphi report will certainly help to ensure that we have some consistent diagnostic criteria we all know that what we're looking at. This will help with the MDT to work together and have a foundation for good, productive case discussions. From there, we can identify clear referral and treatment pathways, get an equitable access to specialist clinics. Lipoedema clinicians are few. There's not many clinics that I am aware of that where we have lipoedema clinicians. It's improving, and hopefully where there will be this equality of access for both lipoedema alongside the lymphoedema to NHS services rather than having to go privately, which an awful lot of people are having to do now. We need to maintain open and honest communication with each other and stay curious. This is how we learn. I learn from every single patient I meet. I hear their stories, what their journey has been like, and they teach me things. And this keeps me curious about what we can do to make things better. And I think this is something that we all need to do as health professionals, is stay curious. Ask the questions, why? What can we do? What can make things better? How can we change things? However, there's always barriers to self-management and integrated care. And sometimes they can come from the patients, but sometimes they can come from health professionals. For patients, they may have had a bad experience in healthcare already. They might have found that they have been fat shamed. They've been told there's nothing you can do, live with it, get on with it. They may well have a lack of insight about what their condition is, no awareness. They've been shunned away. They've been told, oh, just get on with it. And they don't want to know more, which is a shame in many cases, because actually sometimes changing that attitude, gaining that insight can really help people to take a step to manage their condition and take ownership of it. But some people are unwilling to change. They might be scared of change. They might be scared of getting it wrong. They might have poor self-image, lack of confidence, or lack of self-esteem, and for that reason not want to engage in changing that. This might be their safe space for them. So we need to work with them to try and change and challenge those behaviours in a safe way. With health professionals, again, it may be down to a lack of understanding of what the condition is. They haven't got the expertise. They don't want to be seen, though, to not know what they're going on, so they can be quite dismissive about it. There's the lack of specialist clinics. There's poor communication between health teams, and they're often negative attitudes. Again, this fat shaming, you're fat, lose weight. So, long-term aims. I think we've made incredible progress in the last 10, 15 years. There's still a long way to go, and that's been demonstrated in the Lipoedema UK report, the big survey back in 2014, and in the Delphi report this year. But it is so encouraging to see where we're going to. There's a lot to do yet. And I feel very positive. I think for MDT working, we will have clearer pathways, which will lead to accurate diagnosis and treatment in the future. Further research will help to enhance our knowledge base and lead to a better understanding of lipoedema, and that in turn will lead to good shared practice, evidence-based interventions, finding out what's working, what's not working. There's lots of discussion at the moment about the fat loss jabs, the GLP-1s. There's still a lot of work we need to do on that, and we need to collaborate for further treatments, look at liposuction, what surgical interventions are appropriate and what we can get available on the NHS, and ensure equitable access to good MDT care, regardless of the area. Let's get rid of the postcode lottery. And this will lead to a reduced burden on the NHS with proactive early treatment. But more importantly, it's going to mean that our lipoedema people are listened to. They are acknowledged, they are heard, and they are treated with respect. Thank you.
Thank you so much, Sarah. That was very interesting and given us lots of food for thought for our panel discussion later. I'm delighted now to introduce our next speaker. It's Linda Ann Khan, and Linda's the Director of Lymphatic Services in San Diego, Lymphatic Therapy Services in the United States. And Linda's been a therapist for over 35 years and has experience as a clinical aromatherapist and a board-certified massage therapist. She's co-author of the Standard of Care for Lipoedema USA and the Lymphoedema and Lipoedema Nutrition Guide, and is also a founding member of the Lipoedema World Alliance. She's going to talk to us today about a holistic approach to managing lipoedema and the role of nutrition. Thank you, Linda. Hand over to you.
Such a pleasure to be here. And the last speaker, that was fantastic. I loved what you said. It's exactly how I work. We have to have a holistic, integrative approach. Today, we're going to just talk a little bit about metabolic and inflammatory drivers of lipedema and evaluating evidence-based nutritional strategies for symptom management and the role of nutrition in lipedema management, and then how we can help our patients. It's been shown internationally that lipedema now belongs to metabolic medicine, and inflammation modulation is a crucial factor, and helping with insulin regulation. And we need personalized and individualized nutrition. We need to look at the psychological well-being of our patients, and really very important, as our previous speaker spoke, to have a holistic multidisciplinary care. I just wanted to touch on this briefly. There is metabolic dysfunction in lipedema fat, and this is really relevant to nutrition and why we're doing the nutrition programs that we are. But the recent research is showing lipedema tissue may have a weakened blood vessel barrier, and lipedema is complex, not simply excess fat, but a complex disorder involving adipose biology, vascular function, and hormonal signaling. And inflammation is at the root of everything, and this low-grade inflammation will drive fibrosis. And when there's fibrosis, that will drive more inflammation, and there's inflammatory cytokines. And then there's insulin resistance, and many of our patients have insulin sensitivity, which then leads to insulin resistance. And anti-inflammatory nutrition, which we're going to talk about, with high in omega-3s and polyphenols and low glycemic foods, may help to modulate these pathways. So we want to improve insulin sensitivity through dietary strategies, and it can be done, and then have metabolic resistance. This is a busy slide, but basically what we're talking about are the drivers to the disease progression. Insulin resistance, chronic low-grade inflammation, and hormonal influences will affect adipose tissue dysfunction, and then the fat tissue becomes abnormal and resistant to diet and exercise, and then there is a disease progression. But nutrition can interrupt this cascade. And if we interrupt it with low glycemic and ketogenic approaches, we can improve insulin sensitivity. And so the Mediterranean foods, we would reduce inflammation and blood sugar stabilization. With antioxidant-rich foods, which also are high in polyphenols, we can reduce that oxidative stress, and when we have adequate protein, preserving lean body mass, we really need to support mitochondrial dysfunction. It's really important with lipedema. We want to slow the disease progression. Hydration is important. The fascia are involved, and if the tissue is not hydrated, the fascia will affect the lymphatics. So we want to support lymphatic flow and reduce edema, and then of course integrated with movement, lymphatic therapy, and many, many more things. So the emerging understanding is that lipedema is simply not a fat disorder, and it's increasingly recognized as an inflammatory metabolic connective tissue disorder, not as obesity. So it's very complex, and it does clearly require a compassionate, multidisciplinary approach, because the metabolic dysfunction can contribute to insulin resistance, inflammation, mitochondrial dysfunction, and lymphatic impairment, and that will drive more pain, more fibrosis, and then vascular dysfunction. And when that happens, there's more adipose tissue dysfunction, impaired lymphatic flow, and progressive fat accumulation and pain and edema, which leads to the disease progression in lipedema. Nutrition is not a cure, but it is one of the most powerful tools we have to reduce inflammation, improve metabolic resilience, support lymphatic function, and improve quality of life. I have stage 1 lipedema. I have reduced in size and in inflammation, and through nutrition and lifestyle, I am like a poster child for what can be done. And so I inspire all of my patients on a daily basis to do all of this. I wanted to briefly talk about the GLP-1s because they do improve insulin sensitivity and reduce metabolic inflammation, and they may improve the metabolic environment surrounding lipedema, even if they do not directly shrink the lipedema fat. Anecdotal studies are showing that from the trizepatide, there is a reduction in inflammation. We need so many more studies. Fourier identified metabolic dysfunction, and there is emerging reviews, but it's still not a proper trial. It was just not a large controlled trial talking about the trizepatide helping. So I'm really excited to see more about that, because anecdotally we hear every day in the clinic the effects. So evidence-based nutrition for symptom management. Research suggests that lipedema is linked with chronic low-grade infection and metabolic dysfunction. So clearly what we need to do with our nutritional goals is to reduce the inflammatory burden, which could improve insulin sensitivity. We want to support a healthy adipose tissue function and that extracellular matrix and the functioning of the tissue and the fascia. We want to reduce swelling, pain, and heaviness and preserve muscle mass. When patients are on the GLP, they don't have enough protein, they will lose muscle mass. And if they don't have enough fiber, then they can get kidney stones. So it's very important to be observing all of those. Basically, an anti-inflammatory diet can quench the inflammation, and that's a diet high in vegetables and fruit and omega fatty acids. It's similar to the Mediterranean diet, but incorporating low glycemic carbohydrates that are high in fiber, because that fiber is so important, such as quinoa, beans, and lentils. Good fiber leads to gut health, and gut health helps to the brain health too, because there is a connection between the gut microbiome and the brain, so that's really important. Healthy fats, and patients should avoid refined carbs and sugar, and I work with my patients to help them slowly, one by one, leaving out and reducing many of these refined carbohydrates. They shouldn't be having them at all. And the Mediterranean diet patterns do reduce systemic inflammation and support metabolic health. Some beautiful pictures, isn't that wonderful? All these essential fatty acids. Emerging research is showing potential benefits for reduced body weight and body fat from a ketogenic and low carbohydrate diets. Some of the studies have been on ketogenic, some have been on low carbohydrate diets. And so the low carbohydrate ketogenic approaches may lower inflammatory cytokines, improve metabolic flexibility, and then help with oxidative stress, and also help with appetite regulation and satiety. The patients are doing the GLP-1s, that's helping them with their satiety. And I'm finding in my clinic that a combination of the GLP and mindfully watching their nutrition and other aspects to their self-care has been tremendous in helping lipedema patients. And so several studies here showing that the ketogenic diet may mechanically help alleviate insulin resistance, which is one of the contributing factors, proposed as one of the contributing factors in lipedema. And we need all of this can reduce pain, and the lowered carbohydrate may support reduced glycolysis and reduced inflammatory signaling. We really want to look at the mitochondria of the cell, the energy of the cell, and this can help with mitochondrial dysfunction. And reducing carbohydrate intake may also help decrease fluid retention and lessen lymphatic system overload. A randomized trial found that an energy-restricted low-carbohydrate diet improved quality of life and was superior to a standard control diet for reducing pain in women with lipedema. And there was a lipo diet, which really was a pilot study, reported that a ketogenic diet may improve pain and quality of life. So possible mechanisms is reduced insulin spikes. I like my patients to wear continuous glucose monitors to really help them identify what is spiking them individually. improved metabolic flexibility, reduced fluid retention, lowered inflammatory signaling, and that's exactly what we want, and possibly affecting pain pathways. So if we can control all of these, we can really help. And so these findings suggest that a ketogenic diet rich in anti-inflammatory and antioxidant nutrients can reduce systemic inflammation in lipedema patients independent of caloric restriction. This suggests that ketosis may be most useful when paired with high-quality anti-inflammatory foods, not a highly saturated fat ketogenic pattern. And I think that's very important. And when I talk to you about the Mediterranean keto, this will apply too, that to have high-quality fats. Evidence-based medicine has suggested the Mediterranean style eating with low glycemic or lowered carbohydrate, adequate protein, again, to preserve the lean body mass, omega-3 rich foods, and then reducing, I think, the ultra-processed foods and added sugars, which are prevalent here in the US. They should be banned. I really think they should. And individualized plans need to be based on labs, lifestyle, tolerance, and sometimes culture. You have to, is the person a vegetarian? You really need to have an individualized plan. It's not a one diet for all. It's precision nutrition to reduce the inflammation, support metabolic health, and improve quality of life. Those are our goals. It has to be individualized. The S2 guideline, which from the German Society of Phlebology, which was actually presented at the World Lipedema Conference in Rome, they formulated 60 recommendations and agreed on diagnostics, conservative, and surgical treatment options for psychosocial factors, nutrition, and self-management. And so the nutrition guideline states that nutrition may help manage body weight, improve overall metabolic health, reduce lipedema-associated symptoms, improve response to therapy, and it also discusses Mediterranean diet approaches, ketogenic diet approaches, anti-inflammatory, and of course, individualized nutritional counseling. And they spoke about, Faber spoke about reducing insulin spikes, improving insulin sensitivity, reducing inflammatory signaling, and reduce pain and heaviness in some patients. Nutrition is key to lipedema patients. The S2, the guideline also spoke about a Mediterranean style diet with olive oil, avocado, nuts, and seeds, and then lowering the inflammatory load by reducing ultra-processed foods and refined sugars. And thus we can support cardiovascular and metabolic health and reduce inflammatory signaling and that oxidative stress. The Mediterranean ketogenic diet, there are few clinical studies specifically for lipedema, but some have suggested the Mediterranean diet or ketogenic diets. There was one study done, a low-calorie ketogenic diet for 8 to 12 weeks, followed by a maintenance phase with a time-restricted intermittent fasting, and then they had good results. Most studies lack weight-matched control groups. The Mediterranean-style ketogenic diet, which really I realized after I saw this research in Rome, was this is really how I have been living in for the past probably 20 years. The diet suggests about 50 grams of carbohydrate a day, as opposed to the strict ketogenic, which is usually only 20 grams of carbs a day. And they emphasized all the good essential fatty acids and anti-inflammatory foods. And they had their own dietary inflammatory index score, and they could measure how the CRP and the IL-6 was reduced. And they reported reductions in body weight and visceral fat, and then a reduced leg circumference. So this suggests that ketosis might be most useful when paired with high-quality anti-inflammatory foods, not a highly saturated fat ketogenic pattern. So lipedema is metabolically and biologically complex. Nutrition matters. Inflammation matters. Body weight management matters, and this is always a challenge for the patients one of the slides somebody showed, one of the speakers showed with a really large stage 4 patient with a lot of obesity. And there's no single evidence-based lipedema diet, but the current evidence does support anti-inflammatory nutrition, metabolic optimization, individualized dietary strategies, and comprehensive multidisciplinary care. So basically, anti-inflammatory and metabolic effects may help improve insulin sensitivity, inflammation, body composition, symptom burden. And our goal with our nutrition is to identify realistic, sustainable dietary strategies that support lymphatic flow, metabolic health, inflammation reduction, which is key, and therefore improved quality of life, which is what we want for all of our patients. So we want to reduce refined carbohydrates and sugar, emphasize low glycemic foods, pair proteins with meals to improve satiety and insulin balance, focus on the anti-inflammatory foods that I showed you, support lymphatic function with hydration, which will also help your fascia, adequate protein intake, mineral-rich whole foods. I like to tell my patients to eat the rainbow. You're getting all the beautiful polyphenols and bioflavonoids from the foods, and reduce sodium from processed foods. Combine nutrition with movement, compression, lymphatic therapy, stress reduction, breath work, meditation, sleep optimization, which is so key to help with metabolism. And the best nutrition plan is sustainable, individualized, realistic, enjoyable, and culturally appropriate. We must have a patient-centered approach. There is no single lipedema diet. We want to reduce that inflammation, but small, consistent dietary changes may significantly influence inflammation, lymphatic function, pain, energy, and quality of life in individuals with lipedema. And it's not all or nothing, it's all or something, taking small, small steps. So to summarize, you cannot separate lipedema from metabolism, inflammation, and lymphatic flow. Lipedema is a metabolic inflammatory disease, not a fat disorder, and nutrition directly influences insulin signaling, inflammation, and fluid dynamics. Stabilizing blood sugar helps to reduce adipose dysfunction and symptom progression. Anti-inflammatory nutrition supports lymphatic flow, and sustainable change comes from simple, consistent daily choices, which is the message to patients. And then the final message, I promise you this is final, lipedema is a complex, systemic, metabolic inflammatory disorder. It's not obesity, simply obesity. There is obesity with it often. Insulin resistance matters, and anti-inflammatory Mediterranean style eating is appropriate, and having low glycemic or low carbohydrate approaches. No one-size diet fits all, and dietary changes influence inflammation, lymphatic function, pain, energy, and quality of life, and I venture to say the progression of the disease. So thank you very, very much.
Thank you so much, Linda Ann. That's it's really interesting topic there. It's always a really hot topic for patients, and anecdotally, I've definitely had some of my patients really have benefit with that anti-inflammatory way of eating. So thank you so much for sharing. I believe we're now going to a video looking at the experiences of self-managing lipedema.
Hi, I'm Summer and I have lipedema. So how do I self-manage lipedema? So I sometimes dry brush. I use my vibration plate, which is a godsend. I use it every day for 10 minutes in the morning and 10 minutes in the evening, and sometimes in the middle of the day. I don't know what they're called, but I like those inflating tube things that I put on my legs from the lymphedema clinic. I also used to go to aquablast or swimming, and that's really good for the lymphatic drainage and for my legs. And compression. So what helps me is that I just have low expectations of my body, to be honest. I think with a lot of people with lipedema, we have a lot of multifaceted issues, stuff like hypermobility as well, POTS, lots of other health issues which affect women that are really poorly researched, and we don't really know what connects them, we don't know why. So I'm in that group, and I think that generally helps me not try and achieve too much, because if I benchmark myself against other people that don't have all these interlaying issues, I just end up being really hard on myself, feeling really disappointed and frustrated that my body can't do that. But also I go to the gym, I try and move my body, I try and eat what's good for my body, and what I've learned is that certain things make me flare up, and this will come on to food and diet in a sec. Mushrooms, alcohol and processed sugar make me flare up. They give me flare-ups, they give me pain, they make my legs feel really inflamed. And what I've learned after 35 years of living is that an anti-inflammatory diet is different for everybody. Everybody will have different foods and items that they put in their body that they will react to, which is wild, because I just thought that an anti-inflammatory diet was a set list of foods. And yeah, there's some stuff which does cause inflammation more than others, but I can guarantee that some people will find mushrooms to be fine where they make me feel really inflamed. So an anti-inflammatory diet is what your body responds to in an inflammatory way. It's not a set list of foods. So I do manage the lipedema in my upper legs and in my arms through conservative methods. That brings me on to what advice I would give to someone newly diagnosed, and I would give advice on conservative methods. Use them. Use them first. Don't jump straight into surgery. Use the conservative methods of managing your lipedema. It's difficult because you've got to form habits, and habits are hard to form because it takes consistency and motivation and a lot of time. So creating those habits of dry brushing, of swimming, of rebounding. Oh, I forgot about that. I have a rebounder as well in my self-care. Of rebounding, vibration, you know, all those concepts, do those and do those habitually. And then once you've kind of got to a place where they're a habit, you do them all the time, and you still find that this is really unmanageable and I can't kind of facilitate this in my future, then look at surgery. That would be my advice. I would also advise people not to believe what they see on social media, because I don't know what's happened with the lipedema community recently over the last couple of years, but there are so many people trying to make money. I'd really ask people just to think a bit harder about what they're seeing on social media and what they're being sold independently. Go away and try and look at some studies related to that supplement, related to that medication, and do your own due diligence, do your own research.
I was diagnosed with lipedema, I think 2 years ago, by accident. As far as management goes, I wear my compression Monday to Friday. I don't tend to wear it on a weekend, and I think that helps. It helps keep my legs feeling tighter. I run 5 days a week. I have had periods where I've run 7 days a week, but I am being sensible. I run 5 days a week. I do yoga and I do some strength work, and I think the running has helped. I think that, like, kind of a bit like rebound therapy, the bouncing, the motion seems to help. My legs feel better when I flush them out in the morning. I'm seeing the benefits of the yoga and building that in, and yeah, just the compression, and I think staying active. And I do drink a lot. If I've not drunk as much water, I can tell the difference in my legs. When I was first diagnosed, I think I was in, again, a bit of a lucky position because of watching Mom deal with lymphoedema for so long. I kind of knew bits about lipedema, but I knew more about lymphoedema. But you can fall down some rabbit holes on the internet, and I think my advice to somebody newly diagnosed would be do research, but don't fall for all the influencers that are out there now that will do a before and after and show you lovely slim legs, because that's not reality. They are just, it's clickbait, and they're just trying to get money out of you some way or another. Yeah, I'm lucky that I got it early, and that's just what works for me. And we're all just figuring it out together.
Thank you, everyone. That was really interesting to hear those patients giving their personal stories there. So just to going on to the panel now, we are getting a little bit short of time, so we're just going to perhaps do just some top tips from each of our speakers. Sarah, just to say, obviously a theme within the questions coming in is about how to get a diagnosis, and my thoughts is with the MDT, how do we engage with commissioners to better commission services to then allow other stretch services that are members of the MDT to really get on board and get involved.
I think it's important to engage with your health professional, and if you can get a GP or clinician on side, is actually work with them to go to the integrated care boards and say, we need to have service here. If you don't have anything in your area, say, why aren't we getting this? We need equality in treatment. And parity in that respect. But also, you'll become the expert in many respects of your own condition. Do the research, get the information, take that to your GP, tell them about the RCGP online course, tell them about Lipoedema UK, tell them about the Delphi documents. Inspire them to get curious. As I say, stay curious, ask the questions, and not just accept no. If you say no, we can't do anything, ask why not, and say, well, what can we do? Can we work on this together? So try and encourage your health professional to work collaboratively with you, because that's the start of an MDT. Even if it's just yourself and your GP, that's the start. And then you can bring somebody else, and hopefully you'll get a clinician in, a lymphedema specialist or a lipedema specialist or an MLD therapist. That's your next member. And then sort of look at from there and just slowly build up from there and try and encourage that circle to talk to each other. And I think that's one thing we don't do well enough as clinicians. We don't talk to each other. We stay in our own little specialities, and we don't sort of like go in and say, hey, I do this. What can I teach you? What can you teach me? What can we do together? And I think that's where we need to change our attitudes and really work together. There's so many people that can be involved in a team. As somebody put in the chat, you can look at physiotherapy, occupational therapy, look at gait analysis. It's something that we've discussed a lot within Lipoedema UK. People having problems with walking. Do they need a gait analysis? Is it how it's affecting their hypermobility? Do we need to call in other specialists, a podiatrist, MSK specialists? There's lots of people we can bring in, but ask the questions. And if they say no, ask why.
Yeah, I'd echo all of that. Some really good points there. Just be patient, hang in there, and as we said, that the help is out there, but it's about just not taking no for an answer, basically. I'm quite conscious of the time, so I think in the interests of moving along, I can see Professor Cornely sitting there raring to go. So without further ado, I think I'm going to hand over to Kate Forster, who's going to chair our next session.
Thank you so much, Rodri. And yes, as you say, thank you to everybody. We are delighted to have so many really great speakers with us this afternoon. And we have some absolutely amazing content, starting with my wonderful friend, Professor Cornely, who is always a delight and gives his time to us so generously. You are always delightful, Manuel, I promise you. So what we're going to move on to now is we want to close by really picking up the topic about research. Something that has been said in the chat is a little bit about what else is going on, what have we learned, what have we not learned. I think actually where we are this year is there's even so much more than when we did the session with the RSM last year. So we're going to have our speakers talking a bit about different considerations now on surgical approaches, where we are with NICE in the UK, some reflections on taking some of this evidence forward, what the new research questions are. And I know one of our speakers a little bit later on through this session is one of our colleagues from the Lipoedema Foundation in the US, and it'll be wonderful to get their views. And then we'll try and find some time to squeeze in some questions. But if anybody has questions, do continue to put them in the Q&A box. We'll answer as many as we can. So I'm going to start, Manuel, by handing over to you. We are so lucky to have you as somebody who is, as I say, one of my colleagues in the Lipoedema World Alliance, and somebody who's been a senior consultant, is a professor, an honorary professor, specialist in dermatology, venereology. I think I could probably spend 15 minutes talking about your publications, including one of your most recent books. But if it's okay with you, Manuel, may I hand over to you so everyone can hear more about your work?
I will try to go on as quick as possible because we are up to the time. Do you see the screen? It's shared now.
Yes, we see it.
Okay. So I'd like to thank you very much for inviting me to speak to you for a few minutes on this very night today, and I would like to start, if it's possible. I would like to start with a citation that, as you all know, in everyday clinical pictures, the term edema is not always used in a strict sense, but also for conditions that change body structures in an analogous way. The best known example for such a term borrowing is the lipoedema of extremities. The cause is primarily a cellular fat distribution order that mimics the clinical picture from the black edema, although aesthetic and intestinal edema may occur as phenotypic. Lipoedema is neither an edema nor a lymphoedema, nor it is an obesity. How should we address this misleading trend with edema? I would say best is its work in progress. It best describes this remarkable new findings. We heard of this in the last minutes on this lymphological condition, the correct term for which is, I'd say, lipohyperplasia dolorosa. The main focus on this year's RSM webinar is on the LWA Delphi consensus paper, so I would like to briefly mention domain 4 and the relevant statements from the document for hypothyroidism and hypermobility symptoms associated with lipid. Recent publications highlighted a possible link between lipedema and hypothyroidism. The demonstrated prevalence ranging from 19 to 36 exceeds that of comparable populations after adjustment of sex age and BMI. However, the extent of a causal connection or whether hypothyroidism is merely an epiphenomenon of coincident obesity remains unclear. And the evidence suggests that women with lipedema exhibit diseased elasticity in both skins and aorta, along with joint vulnerability and muscle weakness. There is speculation, and it's really a speculation, about a link between lipedema and the connective tissue disorder, especially hypermobility spectrum disorders with poor HSD, although no conclusive underlying mechanism has been identified yet. Further investigations is needed to confirm a definitive association between lipedema and this HSD. But in particular, here today, the focus is on coincident obesity and lipedema, a disease that I prefer to call lipohyperplasia dolorosa. So, obesity. This is a big, literally heavyweight problem for the health of the people and for the entire population. Some clinical studies estimate that between 38 to 85% of people with lipedema also have clinical obesity. I really don't know the exact numbers of obesity, but they may be so like coincidence. I can well imagine that. However, there's always the problem of how the two diseases are maintained. You cannot conclude obesity from weight alone. I'll talk about this in a moment. BMI and waist-to-height ratio are the keywords. I suspect that the incidence of obesity in the United Kingdom is similar to that in Germany, so we have to assume that frequency is affect at least every second man. The second clinical picture that we are dealing with today is lipohyperplasia dolorosa, a congenital symmetrical painful or rather tender disease on the arms and legs. It is known to occur only in women. The body trunk, hands, and feet are never affected. With obesity, the situation is completely different. Here, the trunk of the body and the extremities, although the neck, head, hands, and feet are always changed by the increase of subcutaneous fatty tissue in the silhouette, simple put, too thick. When this is due to a mistake of caloric intake, means nutrition. It is therefore not congenital, but acquired. The proposition may be genetic, but its weight gain itself is acquired, not congenital. This inadequate alimentation or diet cannot consume but accumulates on and in the body, and therefore there is weight gain and a change in the chart of the entire body, visible, and in the organs, invisible. Both diseases, lido and obesity, essentially take place in the subcutaneous adipose tissue. Nevertheless, must be clear for us all that these are two diseases that have nothing to do with each other. Neither does obesity become a lipohyperplasia dolorosa, nor does lipohyperplasia dolorosa ever become obesity. And obesity is never painful, lido always. So pain is the minor symptom of the disease, the signature symptom, so to speak, which can lead to an early clear diagnosis. Think of slim patients in stage 1 or lido who are often not recognized because they are not fat. Obesity is not a minor symptom, nor a signature symptom of lido. These two serious diseases are therefore never comorbid, but always only coincident. They can be found and occur independently in the same person. And this is, as we all know, statistically to be expected for every second lido patient. As little as these coincident diseases have in common, their therapies must also be viewed in a very differentiated way. In some cases, as shown here, obesity can be successfully treated by changing lifestyle habits, especially regarding the diets and the exercise. And you can see this on the picture. This lady got down about 43 kilograms just by diet. Congratulations. Lido cannot be positively influenced by any way of diet or exercise, since it is not acquired but congenital. Stomach surgery seems to be a possible option, but it is not sufficient on its own, because this operation does not change the symptoms of lido. Stomach surgery can halve body weight, but it is always followed by another lifelong dietary change in the supplementation of vitamins and trace elements. Otherwise, the weight can rise again even after such an intervention. New on the market, as you know, are drugs that dampen food noise, thereby leading to change in food intake. As a consequence, patients with obesity can reduce their weight in this way if they do not only take the medication, but also change their living conditions, their diet. Of course, this also applies to patients with coincidence diseases such as obesity and lido. There is experience in this regard at St. George Hospital in London. Christina Gordon knows about it. I cannot contribute anything scientific on this use of the GLP-1 agonist and refer to the colleagues involved in these topics. Interestingly, Christina told me that it has been observed that patients with coincidence of two diseases have a benefit from both diseases. They can reduce their weight as expected. They can also improve the extremity circumference as expected. And at least for some patients, really unexpected, improvements in pain can be noted in the lido. This is particularly interesting for me as a lymphological surgeon and a researcher, because, like all of us, I know that the pain is not related to the volume of the extremities. More or less volume does not cause more or less pain. If the volume reduction by surgical removal of adipose tissue in lido leads to painlessness and the same effect influencing the pain, can also be achieved by a drug, for example, using dipsitoratide, then we would have a possible approach for a change in strategy, away from surgery to medication to the treatment of LIDO. This would be really indeed sensational. However, I can't have any scientific data on this because I'm not active in this research. In general, however, bariatric surgery does not positively affect on LIDO. A few years ago, we presented a short paper on 13 patients. We are currently in progress of publishing an extensive work with almost 200 patients with these questions. This work was currently supported by Lipoedema Foundation and by research during the unfortunately necessary extension. And I'm glad that we have now been able to present the data to the statisticians that have come to interesting results. Confidentially, knowing the upcoming publications, I can say that pain can still not be released by bariatric surgery. It does not matter whether epsilon anastomosis or the bypass or a sleeve gastrectomy is operated. Both can lead to a halving of body weight, while the pain discomfort remains in the subcutaneous fat on the extremities. The signature syndrome of the LIDO remains unchanged. Conclusion: bariatric surgery is not an inadequate treatment for lipohyperplasia levels. It is more important to distinguish between obesity and LIDO when diagnosing the disease, because both must be treated independently. Untreated obesity does indeed lead to significant diseases relevant to internal medicine. I remember and will remind you for the metabolic syndrome, but also for diabetes, high blood pressure, after stroke, and cardiac death. Untreated LIDO leads to a lifelong need of reducing pain, or rather tenderness, through conservative manual or apparatus-based lymphatic drainage, as known, and compression, as we heard this afternoon. Most of the time, it only helps to treat it in combination. This was what Isabel told us. All of this has led to the Federal Joint Committee to preliminary in Germany to preliminary results in the initial assessment of the LIPEX study injury. The results will be published in the Lancet. And let me note here, Lancet has an impact factor of 80.5. I do not believe that any lymphological research has ever been published in such a high level. And allow me to point out that this is also a remarkable achievement for patients now in lymphological science. But back to the new rules in Germany. This Federal Joint Committee has made a recommendation or a set guideline for dealing with patients who wish to undergo an operation on their LIDO at the expenses of the statutory health insurance companies. It has been decided that patients with a BMI below 32 can be operated on with CDT after 6 months of preparation if the pain has not improved. It has also been decided that with a BMI between 32 and 35, in addition to LIDO, obesity must be successfully treated, and that there must be no weight gain during the 6 months preparation period for surgery. And with a BMI over 35, the committee rejects the operations at the expenses of the health company insurance funds. So what to do with the patients who clearly have a LIDO and are in a BMI range between 32 and 35? This is where the waist to height ratio comes into the play, not the waist to hip ratio. Here we can see how to measure the waist to height ratio correctly. Waist to height ratio indicates the ratio between the waist circumference, measured halfway between rib arc and hip crest, and body length. The waist to height ratio is arranged by age group. This ratio makes it possible to reduce the calculation of the weight changes by the arms and legs and not by the trunk as in obesity. BMI is therefore still important and necessary in the differential diagnosis between obesity and LIDO, even though BMI alone cannot be used to measure lido, as it is construct invalid. As you know, it yields incorrect body mass for people standing on the scales. This is also general knowledge and does not need to be deepened by me here. I hope I was able to give you an understanding of the few new concrete aspects from practice, and direct research, and I may summarize them as follows. In Germany, surgeries for the condition lipoprotein has been included in the list of services covered by insurance funds. This represents a significant step forward for the patients. The criteria of surgery have been clearly defined. One of them is the weight class for those with BMI under 32. For a BMI between 32 and 35, waist to height ratio rules apply. For BMI over 34, surgery is no longer covered by health insurance companies. The patients can now influence the course of the disease by addressing their coincident obesity. So there's a downgrading due to weight reduction. Obesity treatment has been integrated into lido. However, this also means that we have finally left staging completely. When implementing these surgical options, we are no longer interested in which stadium the patient is located. Staging was always been just an auxiliary construction. A classification of patients according to visual aspects, but not according to the symptoms of the disease. It is well known that lido is classified into stages 1 to 3 based on appearance. In patients care in Germany, we have now moved away from this system, and I'm really grateful for this. We classify the patients into treatment groups and then offer them therapy. So I know that the extent of the lido at the extremities plays a role in the assignment to such a group. If we continue to know how the pain, an example is signature center, develops and gets worse and not better, and if we also match the information with the weight discussion, then we can form treatment groups which are these simple arguments. This classification is known as stratification and helps to decide whether to opt for conservative or surgical treatment. This leads us to an allocation of the intervention, which is shown here in these next slides. You see the extent, arms, under legs, or just legs. The dynamic pain progression, becoming better, consistent, or worse. We match it with the weights, BMI, and waist to height ratio, and afterwards we can find ways to the intervention. All of them can be quantitative. Some of them can be surgical treatment due to the BMI and waist to height ratio. So, giving you an example, here is simple. We have an extent of arm, the pain improvement, and we can take conservative treatment. We have an extent on arms and legs, the pain exacerbation, and in surgery is possible. So this patient must be in a weight of BMI 32 or a good sharp of the waist to height ratio. The third example, these are legs with pain consistence and no surgery is possible. And this would be arms and legs with pain exacerbation, and pain must be adapted because the waist to height ratio is not clear up to now. So, take home messages. Surgical bariatric therapy is not effective in lido patients. Waist to height ratio is better than BMI and has to be used. The stratification is better than staging, and medication will be a very interesting thing for the surgeon. Thank you very much for listening to this presentation.
Thank you so much, Manuel. That is so wonderful of you. I know there'll be loads of comments and conversations from people, but I'm going to put a pin in both those thoughts and my own questions. And we do have a patient video, which would be great for us to share before we jump into everyone else. So I'm going to ask the RSM to play that so we can hear the story of another story about living with lipedema from Libby.
Living with lipedema has completely changed the way I understand my body, exercise and health. For a long time, I felt like my body didn't respond the same way as other people's, no matter how hard I tried. One thing I really want healthcare professionals to understand is that lipedema is not laziness, and it's not simply a case of telling someone to lose weight. Many women with lipedema spend years dieting, exercising, and doing all the right things, while still feeling blamed when their body doesn't respond the way people expect. That can be incredibly isolating and emotionally exhausting. For me, learning about lipedema finally explained so much. The pain, the heaviness, swelling, fatigue, and a disproportionate fat distribution. It changed the way I viewed myself and helped me realise this is a genuine medical condition and not a personal failure. I've also been on a very personal journey with my health and weight. I've lost around 5 stone through sustainable lifestyle changes, movement and learning how to work with my body instead of against it. At one stage, I felt like my lipedema symptoms were progressing towards stage 4. But through consistent self-management, I have felt that I've been able to bring things back and manage myself more like a stage 3. That has been incredibly empowering for me because it has shown me that while there may not be a cure, supportive management can still make a huge difference to symptoms, mobility, and quality of life. I think that we urgently need more awareness and education, especially for GPs and frontline healthcare professionals, so patients can be recognised earlier and also supported properly rather than being dismissed. Sometimes the biggest difference starts with simply being believed and understood. In terms of self-management, I have learnt that what works for me and my body, rather than forcing myself into approaches that aren't sustainable. Exercise has helped me, but especially low-impact movement. Swimming has been one of the most positive things for me because it allows me to move comfortably and consistently. It helps with mobility, confidence, and how heavy my legs feel day to day. I've also become much more aware of how nutrition affects my symptoms, inflammation and energy levels. A lower carb, anti-inflammatory style of eating has helped me personally, particularly a Mediterranean style approach focused on whole foods, protein and balance. It's not about restriction or being perfect, it's about understanding what makes my body feel better and more manageable day to day. Compression has also helped me manage discomfort and support my symptoms, although accessing the right garments and finding options that are comfortable and practical hasn't always been straightforward. I think people often underestimate how much lipedema affects both physical and emotional well-being. Patients end up becoming experts in managing their own symptoms through trial and error because we live with it every single day. For anybody newly diagnosed, I would say be patient with yourself. Don't compare yourself to people and don't assume your worth is defined by your size or your symptoms. Focus on finding movement that works for you, that feels kind to your body, small habits that support your well-being, and healthcare professionals who actually listen to you. Living with lipedema is more than a diagnosis. It's learning how to support your body with compassion instead of blame.
Hello, everyone. I know we've got a bit of time to catch up, so I'm going to actually be quite quick with this. But what I want to do, or what we want to do, is give you an update on the situation with NICE, National Institute for Clinical Excellence in the UK, and the health tech guidance that has now become a health technology guidance for liposuction for chronic lipedema. So you'll notice those of you that were aware of this from previously, you'll notice that the title has slightly changed. It's more in line with the liposuction for chronic lymphoedema. guidance rather than liposuction for non-cosmetic lipedema. So it's just to say that it's actually the same guideline. So just a quick resume, NICE guidelines are evidence-based recommendations for health and care, mainly in England and Wales, but they're relevant in Scotland and the boards, the health boards in Scotland and Northern Ireland. And they're really here to support health and social care professionals with their work. They're also there to help identify what medications are, what's cost effective, what's effective, and what should be used within the NHS. One quite exciting thing is that NICE are saying that presently they're prioritizing certain areas, and you can see that women's health is part of that. So I do say that they are interested in lipedema, and I'll show you a bit more about that. So just to go back to previously, the liposuction guideline, there was a kind of history behind this, and in March 2022, NICE published the review of the evidence for liposuction for lipedema, and it came under an interventional procedure guidance at that point, and they looked at the research that was available at that time, and their recommendations were, as many of you will know, more research is needed, evidence is inadequate, there were concerns about major adverse events, and they said that liposuction procedure should only be used in the context of research. So I know that had quite a major effect in many ways, and made things very difficult, but we have been working very much with NICE since then, and there are one or two things happening which will be of interest to people, I'm sure. So if you go on to the NICE guideline now, this is the front page for the chronic lipedema NICE guideline, and you'll notice that it's actually been last reviewed in August 2025. And you'll also notice that NICE is well aware of the LipLeg study that Manuel has been very much involved with, and his colleagues in Germany. And that's really quite exciting. We're waiting for that to be published, and NICE are very aware they're waiting for that to be published. And just to show you, in fact, that this is some of the pending evidence that we're waiting for, the LipLeg study in Germany, and Poda et al. Had published the protocol for that. And there's also a similar study ongoing in Norway as well. And one of the things that I'll just point out to you, I'm just trying to be quick with this, but as well as this study, these studies being about surgery, they also do take into account conservative treatment. And that's really important as well. But that shows us that we're not just talking about surgery, we are talking about all the other aspects of lipedema treatment being important here. So at the moment, we are waiting for studies, particularly the LipLeg study, to be published. And that's hopefully going to be published in a journal quite soon, in a medical journal. And we're waiting to see if NICE will then undertake another review with their review committee, independent review committee. However, we have been working away with them. Lipoedema UK continued to collaborate with them, and this has been ongoing over several years. We've got a lot of friends now and colleagues in NICE, which is great. In March 2026, 3 of us attended the NICE conference in Manchester, and we were invited to be the only condition-related charity that exhibited. And we actually had our big stand right next to the coffee queue, so it was, they couldn't miss the pictures. So we felt that we made a bit of a point there, which was great. And also we've been, Lipoedema UK are involved in NICE Voluntary and Community Sector Forum, which is, as they call it, the patient voice. So they're encouraging us to get involved in other guidelines that relate to lipedema as well, in terms of the obesity guidelines, etc. And we're now working, hopefully, with them towards some sort of submission for prioritization to be in their clinical knowledge summary programme as well. And if you're interested in that, you can have a look on the NICE website. And that's basically another type of guideline that is particularly useful in primary care, showing us the pathways for care, etc. And that's going to be really important, because even if NICE do accept that surgery is safe, because we're now beginning to see some really good evidence that it is, and we know that, we still need an infrastructure, as I mentioned before, for surgery to take place in the UK. It's not just about the surgery, it's about all the care around that. So a couple of photos at the team, Lucy Price and Mary there at the NICE conference with Helen Crosby, who's one of our links at NICE. So watch this space and keep your fingers crossed as well. And we'll keep Lipoedema UK will keep you up to date. Thank you, Kate. That's me.
Okay, excellent. Well, I'm just going to apologise in advance. It is 3 a.m. where I am. Thank you very much for the kind invitation to present here some of the current evidence and what we know so far in lipedema. As you said, I'm a reconstructive microsurgeon. I specialise in lipedema and lymphedema, which was what my original PhD was in. And I'm the director of the O'Brien Institute, where we have a couple of labs set up in this space. I have no financial disclosures to declare. As we've heard from other presenters, there is a very heterogeneous presentation inherent to the lipedema condition. And the key things, in my opinion, are to understand what the level of impact and impairment it might be for one's patient. And looking at those different diagnostic criteria, probably the most important for me is the refractory adipose tissue to weight loss. We've already discussed in previous speakers' talks how the staging system is inadequate, and I won't touch on that too much, other than to say that the key example is that the presence of lymphoedema makes a patient's presentation stage 4, whereas it might actually be that they have quite mild distribution of adipose tissue. And so the realities of dealing with fat are that there is two sides to the adipose tissue coin. There are the fat that we want to create, and there's the unwanted fat. As tissue engineers, we want to create and graft fat, and also to restrict the obesity, lipedema, and lymphedema fat. And in fact, looking at them under the microscope, they can be somewhat confusing even under the histopathology microscopic examination. This is not a new finding. 60 years ago, Australia's first plastic surgeon, Sir Benjamin Rank, found similar findings, that they were, in fact, quite difficult to see. And in fact, in the clinical sense, the aspirations of patients then were quite evident, although they were treating them by excision of tissue and skin grafting, as opposed to the modern treatment of liposuction we see today. And so in envisaging what new approaches for the new age, we must integrate into this, as other speakers have said, a new way of diagnosing and classifying the disease, a new way of shaping the patient disease manifestation into something that they want, in the context of both the individuality of the patient disease and of the actual patient comorbidities and other factors. And so, can we do better? Well, to do better, we need to know what the patients want. So here's an example of a patient who wanted treatment by liposuction and tissue excision to be able to take a trip to their ancestral home in Italy. And so they were able to undertake walking 10 to 20,000 steps, but came back with a new focus that they were unhappy about this protuberance on their knee. And so it's important to see that what patients want sometimes changes and the perspective sometimes changes. But over about 150 or so patients who underwent a questionnaire of what was important to them, the unanimous theme was that there was a combination of both functional and aesthetic outcomes, but most importantly amongst these patients was a signaling of hope for a better quality of life to come. Amongst treatments, the common theme is often liposuction, and of course liposuction is not just cosmetic, as we've heard. The key thing is, in the context of all the other comorbidities, we must remain true to the concept of first do no harm as doctors. What does the individual treatment teach us about each patient? What is the best treatment for each patient? Again, back to what their expectations are. And here's a series of patients treated with liposuction only on the left-hand side, treated in a variety of centres, who then present somewhat surprised and a little disappointed on occasions with their outcomes. And so as the treating surgeon, it becomes difficult to navigate because there is, of course, an unseen damage to lymphatic vessels and blood vessels, as well as the soft tissues, when you come back and the patient has healed from the original treatment that you weren't involved in. And so that speaks to the importance of timing and staging. We must understand up front what the patient needs and to deliver that hopefully in the first treatment. So the quality of the surgical outcome then depends on the patient's ability to undertake rest and downtime in their busy schedule, either as a professional or a family member. It also depends on their aspirations and expectations, as well as their appetite for undergoing surgery that might entail a contour irregularity, generation of loose skin, or a scar. And so the patient factors, the individual factors, we've tried to break down for simplicity to analyse these individually into the adipose tissues and stem cell component, the connective tissue and extracellular matrix component, as well as the lymphatic and inflammatory component. Can scientific understanding help us to better define surgical pathways appropriate for individual lipedema patients? And can we also help to reverse the comorbidities that result from the manifestation of lipedema? In order to simplify the complex vicious cycle that often exists in the tissues of our lipedema patients, we try to break these down into mini cycles that are more easily addressed as individual components, such as the lymphatic fluid component, the adipose tissue component, and inflammatory component that then lead to the collective manifestations that we see. And so the same is reflected in our research program. Our research program originally started with lymphoedema, where my PhD lay, and moved into tissue engineering and the mechanisms by which we can enhance fat. And of course, we're better to learn, but the areas of unwanted fat that grow unwanted. And so this breakdown then, starting with the fat cell component, we started with an omics platform, i.e. metabolomics, lipidomics, proteomics, genomics. And we studied both the tissues in lipedema and BMI-matched non-lipedema patients, as well as the functional and molecular driver genes behind those, to understand first the lipedema microenvironment and then the patient. So morselizing the tissues then into a subcomponent, we're able to use cell surface markers to subselect cells into different components, including adipose-derived stem cells that make up the tissues. And we found, first of all, in the left-hand panel, that there was a higher number of stem cells present in lipedema patients, but also, more excitingly, that there was an identifiable pattern of stem cell differentiation and different types of stem cells present in lipedema patients. And so looking at the genes that were differentially expressed in those tissues, we're able to identify some genes for further study. And the summary of that work was that we were able to selectively inhibit some of the genes that were upregulated to alter the behavior of these stem cells, both in growth, migration, and their characteristics that led to development of disease. And so as biomarkers, then we look at the imaging side of it. The imaging side of it looks at the, you can see here in the DEXA scan, you can see the yellow depicts the adipose tissue layer, pre-treatment, the restriction of the lipid component after treatment of one leg, and subsequently the second stage. But of course, this doesn't differentiate the disease fat from the normal fat, as we are able to do at a molecular level in the lab. And that is the holy grail we are now searching for, because it leads so importantly to the diagnostics, but also to the funding mechanism. The next component, connective tissue, what do we know about that? Well, as a surgeon treating this disease, you can see that we've treated one side first, the left leg that's healed. We're coming at treatment of the right leg now, and you can see that the liposuction creates loose skin. As the loose skin is created, we can see inherent differences in the collagen quality, the collagen makeup, the thickness, and the characteristics that go along with the genetics that we can observe from gene screening as well. So there's clearly something going on in the connective tissue compartment of this disease. And a paper that Anne alluded to in her earlier talk was this paper we produced in 2024, where we found that there was an autosomal dominant inheritance pattern in the lipedema families we looked at, with a strong predisposition to extracellular matrix genes, but no particular single gene that was responsible for all cases. And just to answer a question about the link to obesity and lipedema, the POMC gene is linked to obesity, explaining why one sibling with lipedema may have the same diet as the other siblings, but they gain the other additional problem of obesity in addition to their lipedema. We also found collagen dysregulation and genes that also linked to Ehlers-Danlos syndrome, easy bruising, and the hypermobility phenomena that we see so commonly. So the answer is in the genes. We just need to know which genes and where to look. But as this emerges, we will gain more and more. And of course, the most useful thing for me as a clinician is to integrate the genetics of each individual patient into their tailored management pathway. And how do we do this? We've developed what we call the pathomorphometric pathway model to look at the multidisciplinary and multimodality treatment of lipedema. And this essentially is the breakdown of the different areas we've been talking about: connective tissue, the swelling, the obesity and arthritis, and looking at how we individually go through, and depending on which of these vicious cycles exist in a patient, we then address those first to produce optimization in terms of quality of tissues, but also just quality of life as well, and optimization of general health before considering surgery on an optimized patient to ensure superior results for both them and for, of course, the clinician who wants to do their best to do this safely. Here are some examples. Now, this is an early stage patient who you can look at the leg shape and see the classic early symptoms of lipedema, and many patients will feel that there is disproportionate pain and heaviness, even though the appearance is macroscopically relatively mild. But this patient will tell you that their symptoms are alleviated through liposuction and tissue excision. And here's a patient who is slightly more advanced, but again, heavy legs, painful legs, and you can see by liposuction there is a reduction of the lymphatic component that is accumulating in the legs, the pain, and obviously the confidence with the positive selfie sign, where they are happy enough to do selfies where they once were hiding their legs. Patients with Ehlers-Danlos syndrome, often if you just purely liposuck the legs, they will have excess tissue that doesn't bounce back particularly well, and so removal of the tissue in that particular case, and cases with other sort of connective tissue components that often manifest themselves, autoimmune diseases and so on, may be necessary. This is a patient who's had treatment at 24 months and is able to resume their social life with their daughter, as well as their passion, apart from being a nurse, their passion for triathlon. Bariatric patients often present a greater challenge because, of course, they have not only the collagen situation with the inherent to the lipedema, but also they have stretched the collagen. And so removal of tissues is sometimes a key part of that. And so doing that in a manner that respects the individual's collagen makeup and propensity to heal or scar is important. Patients often shift their focus. It's important to be along the journey with patients and to give them the perspective of, okay, the results may not be perfect, but they're an improvement functionally. And of course, looking at the aspirations that patients often have, they're quite similar to what they were in the 60s. It's just the boots are a little higher and the skirts might be a little shorter, but the aspirations are being able to wear the clothing they want, participate in the activities they want, socialise as they want, and to enjoy their quality of life. In terms of the inflammatory and lymphatic side of this conundrum, we won't dwell too much on that, except to say that one of the major risks of doing surgery on lipedema patients are the formation of seromas and lymphoedema. And so tailoring a technique that treats that patient individually, understands these factors up front to avoid or reduce complications is critical. So what are next steps? Along with my wife, Tara Karnesis, who is the collab head, we're looking at the immune subclusters, differences in mast cells and neutrophils between the populations of lipedema and non-lipedema patients, along with our excellent PhD student, as well as looking at mapping the different sites in the body. And we've just had a paper accepted which looks at lipedema as a disorder of adipose tissue heterogeneity with single cell and spatial transcriptomics to look at the different parts of the body and subcomponents to try and understand clusters of disease. Overall, this comprehensive look at the patient's holistic management can be simplified and must be simplified and individualized and tailored to the patient's needs to understand what particular aspects of lipedema are affecting that patient's journey, what are their priorities, and how best to treat them, if at all surgery is their preference. Surgery should inform science, but science also informs surgery in this heterogeneous disease. And the cell identity that starts to emerge through the interrogation of cell-cell interactions will be critical to the future. Lipedema is a unique connective tissue disease. We need to produce a classification system that reflects this and is useful. Clues will come from the interaction between these critical cells. And ultimately, we're looking for a way to treat patients in a manner that is respectful and effective, giving them the most utility in a safe and positive way to get on with resuming their lives and quality of lives to be able to integrate into their families and to society. Thank you for your time.
That's wonderful. Thanks, Ramin. With very little further ado, I think we're going to hand over to Jonathan, who has kindly joined us from the USA. Jonathan is the Chief Executive Officer of the Lipoedema Foundation, who are one of the guiding organizations in lipedema research and who have been involved in a number of very, very interesting projects. Jonathan, as the CEO of the Lipoedema Foundation, joined them about 5 years ago, I think, Jonathan, isn't it? Time goes so fast. So the Lipoedema Foundation carry out, as a US-based charity, a variety of work in advancing the scientific understanding of lipedema. I think, Jonathan, as you're going to talk about the role of the Lipoedema Foundation, other than acknowledging both your history as a professional in life science companies and research, may I let you hand over to tell us about the role of the Lipoedema Foundation rather than me say more about them? So I give you the maximum time.
Wonderful. Absolutely. Thank you so much, Kate, for that kind introduction. And thank you so much to the Royal Society of Medicine and to Lipoedema UK for asking us to come spend a few minutes to talk about the role of Lipoedema Foundation in supporting research and science around lipedema. Can you see my screen and my slides okay?
Yes, they are.
Wonderful. Great, thanks very much. You probably already picked up from my accent that I'm based in the United States, and so that can go a long way to explaining both the differences in spelling about the word lipedema that you see in this presentation. And I think it's also helpful to keep in mind our work is global in scope, especially the research that we fund, but a lot of our clinical work in particular is very much rooted in the United States context. And so, as we all know, there's some differences from country to country, and it's important, I think, for folks to have that in mind. So just a little bit about the Lipoedema Foundation by the numbers. We were formed about 10 years ago. The core of our work is really around supporting research. I'll talk about this a little bit more later in the presentation. There's been some tremendous clinical research that's been presented on this webinar already today. The bulk of what we focus on is what I would call basic and early stage biological research. So we're really trying to better understand the definition of the disease, what makes it different from other diseases. The goal ultimately is to improve diagnosis, hopefully find a biomarker, understand what's going on at the level of the tissue and the cells in lipedema, and in so doing, set the stage for hopefully future therapies that might help slow down the progression of the disease and ideally stop it in its tracks. I'll spend most of the next few minutes talking about the research, but just a couple of notes about some of our other work here. The first is that we do a good amount of work to build the clinical workforce, especially in the United States. And to that end, we have things like a provider directory and clinical resources. This is both because one of the rate limiting steps for people getting access to effective diagnosis and care is the lack of well-trained clinicians. And also, this is an impediment to research. We really do need great, knowledgeable clinicians engaged in the research enterprise. And so we've been really working to grow the workforce for both of those reasons. And we also do a substantial amount of work to educate the general public about lipedema more broadly. And to that end, we have a whole range of supports and resources for people with lipedema as well. Our organization, though, is very much focused on the research, is founded by and funded by patients. And so we, very much take to heart as part of our mission that will support patients in their journey as well. Please check out the URL above on this slide for more information about some of those free resources. On the research side of things, in some ways, we're living in a tremendously positive time in the evolution of lipedema research. After decades of 1, 2, sometimes 0 papers published per year, the last 5 years have really seen an explosion in the number of primary data papers on lipedema that have been published. And fully 56% of the primary data papers published to date have come out in the past 5 years. So this is truly, in a sense, a renaissance around lipedema research. But the reality is that a lot of challenges still remain. I mean, many of the studies that show up in that chart on the previous slide are relatively small studies. They have a small number of participants. And even across studies, there are inconsistent diagnostic criteria. Data is collected in different ways. Diagnosis is done in different ways. And this really impacts the ability to compare studies and pool the data that we see from different studies to draw statistically significant conclusions and insights. At the base of this is the fact that there just isn't a lot of research writ large, funding writ large for research support, and I think this is growing, but certainly not as quickly as it need to. And though we're, I think, making some progress in growing the clinical workforce, especially in the last year or two, this is really a challenge that we're working on going forward. And so to orient the field towards starting to address some of these challenges, in 2023, we worked with a wide range of stakeholders, including people with lipedema, caretakers, caregivers, folks in the research community, scientists, and also clinicians to lay out a roadmap for research in the lipedema field. And so I'd urge you to check out the URL on this slide for a little bit of detail around that. It's quite detailed. I think the summary is that there's a lot of work to do. And I think, one chapter of the research roadmap really lays out the big open questions. In reality, at this point, we have more questions than we have answers about a whole range of things. I won't go into these in detail. I'll let folks read what's on the slide. I think many of these have already been lifted up by other speakers today, but the answer is that there's a whole lot that we still need to uncover about what's going on with lipedema, why some people get it and other people do not, what can cause it, what causes it to progress. And what could ultimately help address some symptoms and set the stage for a cure. I think one of the main challenges in answering a lot of these questions is that our field is relatively nascent, and so we lack a lot of basic infrastructure that more advanced research fields have. So I'll talk about just a couple of infrastructure-related recommendations that we've been working over the past couple of years to try and address to set the stage for hopefully discoveries in the future. One of those is around building biobanks, and just very basically, a biobank or a tissue biorepository is a place where participants in studies can deposit samples. So we basically events to collect samples of blood, saliva, urine, adipose tissue from people with lipedema and from people without lipedema, which we call controls. We also ask them to answer lots of questions about their experience with the disease, and we ask a diagnosing clinician to also fill out a survey about the participants. And all of that data and all of those samples go into a central bank, a physical location in New Jersey, so that when a researcher has a question they'd like to answer, they can apply for access to that. And so to any researchers who may be on the call today, please go check out the URL on this page or email us at biobank@lipedema.org. We have over 130 participants worth of participant samples and data in the biobank that is ready to answer some of the most burning scientific questions. We're not the only ones who are working towards this. So I know this will be recorded. There are a whole host of other full repositories throughout the world. And some of the work that we're doing right now is to try and pool these resources from different labs to try and answer some fundamental questions using some very advanced technologies and techniques to essentially understand, for example, what's going on with the proteins that are circulating in the blood for people with lipedema and how those might be different from control participants. The second thing that I want to lift up that we've been working on is something called a common case report form. So I mentioned earlier that it's difficult to compare the data from one study to the next because often people are collecting data differently. They may be diagnosing participants differently. And this really raises a challenge to do things like what we call a meta-analysis, where you pool the data from different studies and try to draw better and more rigorous conclusions than any one of those studies could answer on their own. So one potential solution to this, which we've been developing with a whole range of stakeholders over the past couple of years, is a common case report form. So it's one form that we would ask anyone who's doing a study on lipedema, especially a biological study, to use to gather the data so that the data can be comparable when it's later. And I'm pleased to note that this has been launched in the world. You can check it out at lipoedema.org/CRF. And we just got notice today, actually, that this has been published in Frontiers with over 30 co-authors. So it's out there in the published literature now. And we've already received some inquiries even prior to publication that folks are using this common case report form. It's meant to scale for your study. So the most basic version is the core, which is all about diagnosis and aligning diagnosis across different studies. But there's a whole range of measures in here that we think folks could use in their studies, and this will all align with the data that we're collecting as part of our biobank study. So all that's about building a research infrastructure, but I mentioned at the beginning of the talk that we support research. And the bulk of that research support happens through our investigator-initiated award program. We just closed an RFP process earlier this year. You can see the details on the slide about the type of support that we provide. We're going to be announcing some of those awards in the coming months. It's a really exciting group of awardees. Essentially, this is about the projects themselves, but also building the workforce, the research workforce around lipedema. And the majority of folks who are receiving awards as part of this latest cycle are brand new to the lipedema field, which is a really exciting sign of progress, that some great minds are joining the other tremendous folks that have already presented on this call today and truly growing the field. In addition to that, the Lipoedema Foundation has started doing some of its own research. So in addition to our patient registry and the biobank itself, we've sought opportunities where essentially no one else has kind of done the work, and we're very cognizant of the fact that we don't want to be competing with others in the field who would otherwise do tremendous work on their own. So I think we're being very cautious in executing some of this work with our own internal scientists. But the topic of GLP-1 and GIP therapies for lipedema is one that's been hot in our field for a long time. For several years, we've been hearing anecdotes from patients and clinicians and seeing some limited case reports in the literature saying that people are seeing some benefit from these therapies. And so we did a survey last year which received over 2,700 respondents, which showed that both on validated measures of global physical and mental health, so the PROMIS 10 global health score, as well as on lipedema specific measures of symptom severity like pain, swelling, heaviness, and bruising, people with lipedema not only are trying these therapies, but they're seeing some benefit with it in terms of improvements in health function and lipedema symptom severity in ways that truly impact quality of life. Like with these drugs in any disease, what you see is a lot of heterogeneity in the response. So the aggregate response is quite positive. Some folks will see a response that's much stronger than this, and some folks have reported that they've seen little response to these therapies. So it's certainly not a panacea or a magic bullet, but this does put some data behind what we've heard in anecdotal form for a few years now. The caveat is that this is a survey. This is not clinical data, and so the next step is to really do some rigorous clinical studies around this, which is something we're trying to get pharmaceutical companies in particular interested in doing. But I think the indication here is positive, and this was submitted for publication earlier this week. Just a quick thanks to our tremendous team at the Lipoedema Foundation, which includes scientists, clinicians, and some really great operations experts as well. We're small relative to other disease-focused foundations in other fields, but hopefully mighty, and I think we're headed in a strong direction. And we also have a tremendous set of scientific advisors who you can see on this call on this slide as well, some of who have presented today. Thanks so much again for the opportunity. If you have any ideas about ways of getting involved in our research, and especially if you're a researcher who would like to talk about access to our biobank repository and samples, please don't hesitate to reach out after the webinar. Thanks again.
Thank you so much, Jonathan. I know there's so much that we could do justice to. So unless any of you have a particularly burning question, what I'd like to do is ask a question of you all, which is, what area would you suggest that people who've been at the session today go away and look into more? So a particular topic, a particular question, or a particular thought that you recommend that people go away and look at, whether it's a resource on your own website, a particular resource out there, or a research paper. What do you think people should go away, look up on your own websites, or go to Google and search PubMed for, that you think would help them take their learning forward from today's session? And you can choose to direct that top tip to either people living with lipedema or researchers and practitioners. So who would like to start with their fingertip Google idea? Jonathan, did you want to start us off?
Sure, I'm happy to
Thank
answer
you.
first. Absolutely. So one thing is that the Lipoedema Foundation just redesigned its website to have a landing page specifically for people with lipedema. This existed, but we revamped it recently in response to feedback from many folks in the community, some of whom are probably on this call. So it's lipoedema.org/patients, and I think that's a great portal to a lot of the resources that I had the time just to flash very quickly on the screen at the beginning of my presentation. I mean, on there are things like a self-advocacy guide. So that's some coaching for how to have productive conversations in the clinic with your providers. Something like a patient's bill of rights. Our clinicians guide, though it says clinicians, is something that we hear from people with lipedema is quite helpful to share with their clinicians to help get them smart about lipedema. As everyone on this call knows, often people with lipedema are in the position of needing to educate their providers about this as their first, encounter with lipedema or point of contact to it. So that's what I would say first. And then the second thing is that we have a patient registry. We need participation from folks all over the world to really truly understand, what the patient experience with lipedema is and generate new hypotheses that we can chase down in the research community. And so lipoedema.org/registry is the URL for that.
Thank you, Jonathan. That's wonderful. So Anne, did you have a sort of Googling topic or a particular website or thought you'd like to share for either practitioners or patients to look into?
Thank you, Kate. Yes, well, I always think a good thing to do when I go away from a conference is say, well, what 3 takeaways have I got? And I write them down and I think about just at the end of the day to what I want to go. So I think everybody's an individual. So I think everybody will have individual things that they want to look up. So I would just encourage everybody to maybe write down 2 or 3 key things that you feel you've learned today or that you want to find out more about. So I think it's individual. And to have a look at the Lipoedema UK website. There's always things changing on that, updating. So I encourage people, if they're new to this, to get in touch with us at Lipoedema UK. We're there to support. So thank you, Kate.
Wonderful, very kind. Thank you, Anne. And yes, people like yourself in our team help make that website really valuable. Ramin, is there something that you recommend people do more looking into?
Yeah. Look, I think when I talk to my patients, one of the overwhelming things that I hear is that that patients come from all different backgrounds and they've been on a journey with their family. One thing they find really encouraging is the fact that there is more research and understanding taking place through groups like the Lipoedema Foundation that Jonathan represents and other groups doing research. So I think 2 things that I would suggest is, one is we have obviously the great tool of artificial intelligence now, which will enable us to, maybe these scientific papers some of us alluded to are not intrinsically as accessible, such as the question Anne was talking about with obesity. Why is obesity more prevalent in patients with lipedema? And even though the diet might be optimized, and I hope that in my slide I helped address that, is that there is a specific gene that we've published that is associated. So the great thing with AI is we can actually go in there, and I encourage everyone to use their favorite AI search engine to keep abreast of summarizing the data that's coming out. And you can do a simple exercise like summarize for me the actual basic research that's happening. And through this, I encourage my patients to interact in a way that maybe wasn't accessible before with the science and translate the science for themselves to realize that. And that seems to give people great hope that there is a movement, there is science advancement happening. And the other thing I'd encourage people to do is to come to the next Lipedema World Congress, because I think that is a really important touch point. And we've found through the previous meetings in Potsdam and Rome, there's this growing interactome, if you like, of people coming together as clinicians, as patients, as advocates, as fundraisers, as researchers. And that coming together has been a really important facilitator of yet further research and understanding. So those are the two things I'd say is keep abreast of it now with the AI that can digest the scientific material in a manner that suits you according to your own background and needs. And the second is please do attend the Lipedema World Congress meetings wherever they happen, because they are truly an inspirational melting pot for everyone to get involved in any level that suits them.
Thank you, Ramin. And you're right. It's been wonderful with the growth in the Lipedema World Congress. We had, I think, about 500 people in Potsdam, 800 last year in Rome. Next year should be our next year. So we look forward to welcoming many people there and continuing to take that work forward. Manuel, I would love to hear what your closing tips are for people, professionals or patients, to go away and look into after today.
I would like to point out and to highlight that you should not believe what quite often is talked on the internet on this disease. Too much misinformation is done there. Beginning the therapy of lipedema just begins with doing the right diagnosis. This means that you need your idea. It's a lipedema, yes or no, what do I have? And maybe you think it's one, but then you need someone who does the palpation of the infected tissue and the legs and the arms and so on. So this is one of the most problematic things I see with my patients. Wrong informations, mostly told via the net and the bubble in the net. I would love to have more well-informed patients and more doctors know what they're talking about when they do the investigations for the patients, and then do the right way to the next treatment. This will be the base on anything we are thinking of. It might be the practical advice, but as well the surgical, the surgery advices, and those scientific advices as well we are looking for. What we need is clear decisions, what is a lipedema and what not, and as Jonathan told us, it's an old thing. We have no biomarkers and we really need them, and we have to go on in this direction, the first one. Thank you.
That's wonderful. Thank you, Manuel. And indeed, I think there's so much more we could say, but it's right now for me to hand over to the chair of Lipoedema UK, Shari Fetzer, to close the session out for us. Thank you, Shari.
Thank you very much. Thank you, Kate. Thank you, all our last panel. I'm completely humbled by your attendance, that Ramin has probably stayed up all night to join in this. Manuel has come from Spain, no, sorry, Germany, and Jonathan has come from America. I mean, this is the community we're talking about. This is the support that's out there, and this is the credible place to be if you want to learn something about lipedema. So I hope the overall outcome of this afternoon is to teach patients to have a positive attitude and how enlightened medical support can overcome many of the challenges they face living with the condition. We've followed many stories over the last 14 years we've been a charity, and often they've started with despair and misery, but they have turned round, and now there are so many examples of personal success through finding the right treatment for that patient. One of the other biggest successes is the increase in early diagnosis. This absolutely must continue. It is not acceptable that such a high proportion of the female population has a condition with no access to treatment. What patients are seeking is a normal life. They want to go out and enjoy an outing with their family and socializing with their friends. They're not people who are looking to win a beauty contest. And they also want to know that the medical community treats lipedema as an equal condition to every other medical condition, and they have access to empathy and care that's appropriate. I am so grateful to every one of our team and our speakers who've shared their stories and all the people who've worked behind the scenes. I'm also immensely grateful to the RSM, who are leading the way as a medical institution in recognising lipedema. And I sincerely hope that this event will have a ripple effect out to all branches of RSM medicine through its students and its members. I also hope that patients will get an insight into the devoted and generous nature of the individuals working away from the spotlight to make patients' lives better. So I will end on what I said at the beginning. If you are a medical professional, researcher, student, or patient, like everybody else has told you, be very careful of what you read on social media. Learn how to seek out reliable sources. And you can't do better than to follow the people today who have shared their passion and knowledge with us. Thank you to the RSM, and thank you everybody who's participated in this today and who will watch this video in the future. This is just the beginning and not the end. And looking forward to seeing everybody at the next Lipedema World Alliance meeting, wherever it is. We're not quite sure where it's going to be yet, but it will be 2027. Thank you so much, Kate. Thank you, everybody. And thank you to the RSM.